all of you. It's a wonderful afternoon for all of us as we are yet again having a webinar under the aegis of SAO. And the concept that was floated by Professor Rajvardhan Azad is, being followed and being done meticulously by consultants, ophthalmologists of the SAARC countries, and it really gives us, great moments and moments of pride. So to begin with, I would like to thank the President and the Secretary of the SAARC Academy of Ophthalmology, and that is Professor O.K. Malla and Professor Rajvardhan Azad. Professor O.K. Malla, who is the President of SAARC Academy of Ophthalmology, is a very experienced ophthalmologist, did his MBBS long back in 1962-63, and then got several degrees and several awards, which includes the Distinguished Service Award at the Asia Pacific Academy of Ophthalmology and the SAARC Academy of Ophthalmology. He has been the professor and head of Department of Ophthalmology at Kathmandu Medical College and has worked in various capacities in various places. He has numerous publications and he has guided a lot of young ophthalmologists and has trained a lot of ophthalmologists to achieve great heights. We have Professor Rajvardhan Azad, who is a professor of ophthalmology. He is the General Secretary of the SAARC Academy of Ophthalmology, has been trained at RP Center, got various degrees, including the FRCS degrees, and has been the past president of Asia Pacific Academy of Ophthalmology, All India Ophthalmological Society, had started the collegium at the All India, including which is one of the new things that he has started, which are several in number, which he started when he was the president of AIOS. He has worked as a professor at RP Center AIMS, the Apex Center for Ophthalmology in India, and has been an advisor to the Ministry of Health and Family Welfare. He has several research publications and awards to his name, and has been a source of inspiration for all of us, has been a teacher to me and many of us who are sitting here. We have another stalwart, Professor Hossain, who has worked as Professor of Ophthalmology and Director cum Chief Consultant at OSB Eye Hospital, Dhaka, has been the past president of SAO and is the president-elect of the Asia Pacific Academy of Ophthalmology and chairperson of the APAO Women in Ophthalmology Standing Committee. She has been the past president of SAARC Academy of Ophthalmology and has been the founding president of the Bangladesh Community Ophthalmological Society as well as Ophthalmological Society of Bangladesh. Has received several awards like Mubarak Ali Memorial Gold Medals and numerous awards she has. And she has published a lot of papers in peer-reviewed journals and has been a teacher of many teachers and has been a source of inspiration for all of us in this SAARC area from where she represents, and she is really a stalwart in her own field. We have Dr. Lalit Verma, who is also one of the organizers, and he is a senior consultant and director of the retina section in the Center for Sight group of hospitals, which is a chain of hospitals in India and outside. He has published, he's fond of publishing, he's fond of scientific activity, and that is why he has worked as the Chairman Scientific Committee of AIOS and also as the Secretary and Treasurer of All India Ophthalmological Society. Has authored books as well as various chapters in various books as well, and has been my teacher, my guide, and a great source of inspiration for all of us. Another organizer who has really worked hard for this event is Dr. Ben Limbu, who is working at the Telangana Institute of Ophthalmology. A big thanks to him for organizing this webinar. He is the man behind this webinar. He's the consultant cataract and oculoplasty surgeon and is also the general secretary of the Nepalese Society for Oculoplastic Surgeons. He is Scientific Secretary of Oculoplastic Society of South Asia and Editor-in-Chief of Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery. He's working as Assistant Professor. He has recently become Associate Professor, which I got to know yesterday, and is a very dynamic ophthalmologist working at Nepal and in the SAARC region. We have Dr. Lalit Pradhan, who is the Chairman Scientific Committee of SAARC Academy of Ophthalmology, and she is highly qualified. She has several degrees, including the MRCS and the FRCS. She has received several awards, like including the Gold Medal Award in her MD Ophthalmology. She has various research publications. She has worked as the president of Nepal Vitreoretinal Society and the scientific chair of the SAARC Academy of Ophthalmology. She is also the chief editor of Nepalese Journal of Ophthalmology and has various research papers to her credit. A very active person, very dynamic academician, and has been really very working actively for SAARC. This is myself, Dr. I am Dr. Rajesh Sinha, working as Professor of Ophthalmology at RP Center, AIMS, and I'm the Treasurer of the SAARC Academy of Ophthalmology. So now I would like to request Dr. Eli to take over the proceedings. I will stop sharing the slides and Dr. Eli will take over from here.
Good afternoon, everybody. It is really nice to be part of this SAARC webinar. Thanks to Professor Azad for making part of this and Dr. Ben, who's worked really hard. Now, I would like to request our President, Professor Malla, to give the opening remarks. Please, sir.
Thank you very much. I think good afternoon, and I would like to, at the outset, welcome you all to this webinar, friends from the region. I hope you all had a pleasant time in the recent festivities. And I'm pleased to see that all of you are keeping well and in good health. We all are passing through a difficult time, pandemic, COVID. The SAARC Academy of Ophthalmology objectives is to bring together members of these SAARC countries and work towards preventing blindness in the region, that we have many common eye diseases. The first SAARC meet was held way back in 1991 in Kathmandu. I can't forget the stalwarts then from India, Professor Agarwal, S.R.K. Malik, and P.N. Nagpal, Radha Mumtaz from Pakistan, and Professor Martin from Bangladesh. I'd like to thank Dr. Raj, Azad, and Professor Daud Khan, Professor Awa, and Professor Nadim, who have contributed immensely to the development of SAARC. We have today many participants, mainly almost all from the region, who are very eminent and experienced, eminent and profs, and they make the panelists and the speakers and the moderators are also very much updated and learned individuals. You can see Professor Dr. Sanduk Ruit and Maipal Saddev, the president of Ophthalmic Society, who are taking part in this webinar. And I'm looking forward to their presentations. And and I am sure it's going to be a great meet. I'd like to thank Dr. Azad again, Professor Lalit, and Namrata, and Dr. Ili, and Ben, and Rajesh for helping organize this webinar, which you are holding today. And special thanks to Dr. Ben, who is the organizing secretary, to bring this webinar to this shape. And the theme of today's meet is cataract, what's next? Cataract is still a common problem in our region. It is #1 cause of blindness. And in Nepal, I think in 1981, from 70% of the blindness used to be due to cataract. I think it has come down in 2012 to about 40%, but still it's the #1 cause of blindness in this part of the world. And I think today we are meeting here and hopefully be able to combat this cataract blindness and be able to wipe out, probably possible, eliminate blindness due to cataract. I think Dr. Reed has got a paper which is going to present, and hopefully I'm looking forward to it. It will certainly be very helpful in eliminating cataract blindness from the region. Anyway, when I talk about cataract, I think my journey, cataract and cataract surgery, way back in the 70s, I remember attending one eye camps, as a non-ophthalmologist medical officer and helping in Graffy knives cataract surgery. And I have reached to now small incision cataract surgery with implantation of the non-foldable intraocular lenses. That's where I have stopped my cataract surgery and I started doing retina work. Anyway, I'm looking forward to eminent speakers, I think, who has so much to tell us about cataract and how we can manage it and hopefully eliminate blindness from cataract, at least from this region. Thank you very much.
Thank you, sir. Thank you, sir, for your welcome speech. Now, may I request Professor Rajvardhan Azad to provide us with the welcome speech, sir.
Thank you very much, Eli. And Professor Malla, the President of SAARC Academy of Ophthalmology, under whose able guidance we are doing this webinar. Of course, before every webinar, I'm taking permission from him. And he has been very kind and very generous in approving without any modification. Then Professor Hossain, who is the President-elect of Asia Pacific Academy of Ophthalmology. It's a matter of pride for us that she'll very soon become the President of Asia Pacific Academy of Ophthalmology, and we will all get a lot of guidance and a lot of benefits from her position as a President of the Asia Pacific Academy of Ophthalmology. We have also with us Professor Mahipal Sachdev, who is the President of All India Ophthalmological Society. And I believe that his very presence here will help us in making this SAARC Academy of Ophthalmology give more strength and give more powers to this organization. And then all my friends from Pakistan, from Nepal, from Bangladesh, from Sri Lanka, from Maldives, from Afghanistan, from Bhutan, I bring greetings to all of you. And before I forget, I want to thank Ben to have taken up this job, because when I told him, he immediately agreed to it. And before again I forget, I want to thank Professor Sandek Rui. He is my favorite, because when Ben asked me who should be the guest speaker, I immediately said it should be Sandek Rui, who could be a best person other than Sandak Ruit. So with this, the basic idea of this webinar was twofold. One was that in this region of SAARC, as Professor Malla said, we are all, in the sea of cataracts. The cataract blindness is our major problem. And I'm aware of the good work done in the SAARC countries. I know what Pakistan is doing. I know what Nepal is doing. Nepal Netra Jyoti Sangh was one of the first few organizations who took up cataract in a massive scale. And they have come up in a big way. Then Bangladesh, of course, we have a lot of friends there and a lot of good work being done in Bangladesh. So is Sri Lanka, and so is, Maldives. I was in Maldives as a visiting professor and as a WHO consultant for preparing their this Vision 2020 program. And then, Afghanistan and other countries, they are also coming up very well as far as the cataract is concerned. The basic idea was to bring everybody on one platform and to have an exchange of technique and the expertise. I believe this webinar will definitely bring expertise, like, Zepto is there, like Femto Cataract is there, all these things are there, and they will discuss and something good will emerge out of it. The second idea of this webinar was that what is next? The title is very apt. Then what is next? We started from intracapsular, even from couching for that matter. So Sushruta time, it was couching. From couching, we came to intracapsular. From intracapsular, we came to extracapsular with IUL. From extracapsular with IUL, we came to SICS, and from SICS to FECO, and from FECO to FEMTO. And from FEMTO, where are we going? The idea was that we should bring out something new so that it should stimulate our younger people, younger generation to do some research in this area. The basic idea of these webinars are these should be exchanged with the practicing surgeon, their expert technique and expertise, and then what we are giving to our younger generation. What next? What is next lying before us? So that was the basic idea of these webinars. I want to close now. Because a lot of speakers are there. They're good speakers than me also. They are there. So I give, this platform to them. Thank you very much for giving this opportunity. And thanks, Ben, again for organizing this wonderful meeting. Thank you so much.
Thank you, sir, for the welcome speech. Now, may I request Dr. Ben to show a nice video of Nepal regarding geography and the cultural part of Nepal, please. There's no sound.
Really, there is no sound I can hear. Is there?
Yeah, there's no sound. Ben? Dr. Ben?
I think once you start sharing now, on the left side, there are two buttons. You have to press those.
So you have to click on the
You
with
stop
audio.
sharing first. Stop sharing first.
With audio.
Dr. Ben is sharing. So Ben.
Yeah. Once you click on the share, then on the left, lower left, there are two buttons. Start audio.
Share video with audio, sir. Share video with audio. The left hand side bottom.
Yeah.
Before sharing, it should be on. Before sharing, just put, yeah.
Krishna, can you help me, please?
No, once you click share on the left side, then buttons will come. You click on the share.
Okay.
First, and then on the left side, you see there are two buttons.
Yeah.
Left lower corner. Put them on. Just click on them.
Yeah.
दोनों click करके then you select. Yeah. Now click. No. Yeah. Press on the play.
Is the sound coming on?
Yes.
Thank you. Thank you. It's such a wonderful video of our country, more diversity and with different ethnicity and the culture. So with this, I would like to introduce two panelists. Let me just show, she is, sorry. She is Professor Namrata Sharma. She's a role model for me, just like Professor Abu Hossain. Both of them are role model for the female ophthalmologist of this region. She's cornea, cataract, and refractive surgery. The service she works in AIMS, and she has many awards and many achievements. She has 2 patents for Natasol and Nata Matrix, and she's brand ambassador for Tear Film and Ocular Surface Society. She has so many international awards, Senior Achievement Award, American Academy Awards, and also Best Video Awards by so many different organizations. She is at present Honorary General Secretary of All India Ophthalmology Society and Regional Secretary of APAO. And she has many publications, more than 450 publications in international peer-reviewed journals. She has authored more than 11 books. She has so many instruction courses, and of course, she is principal investigator in many multi-center trials and role model for me. And another is our panelist. One of the panelists is Professor Govinda Paudel. He's a professor of ophthalmology in Telangana Institute of Ophthalmology. He is the head of Vitreoretina Society, head of Vitreoretina department in Telangana. He has fellowship in Vitreoretina from Royal Victoria Eye and Infirmary, Melbourne, Australia. He has been awarded as gold medal in ophthalmology residency with Distinguished Service Award in APO. He has been principal investigator in diabetic retinopathy project, and he has many paper presentation publications in peer-reviewed journals. Now with this, I would like to ask Dr. Rajesh to take over and then introduce 2 more panelists and start the session. Thank you.
Thank you, Dr. Eli. And it gives me great pleasure to introduce the remaining 2 panelists. One is Dr. Harbansh Lal, who is currently the co-chairman of Department of Ophthalmology, Sir Gangaram Hospital, and chairman, Department of CME, Sir Gangaram Hospital. He has worked as the treasurer of AIOS and has authored a book on phacoemulsification, has been involved in various activities in the All India Society, has been the president of Delhi Ophthalmological Society, and a very good cataract surgeon. So he deserves to be a panelist here, and his words of wisdom and his experience will really help us a lot in learning new tricks. With us, we also have Dr. Irfan Jiva, who works at Aga Khan University, Pakistan. He has been a comprehensively trained ophthalmologist, and when I was going through his CV, I could see that he is trained in many things. He has completed the 7-year specialty training at the Yorkshire School of Ophthalmology. He was awarded the FRC Opt in 2012. He has been a fellow of European Board of Ophthalmologists and has done fellowship at Moorfields Eye Hospital and Birmingham Children's Hospital and Leeds Teaching Hospitals. So after that, he left UK and came back to Pakistan after doing locum consultant in Yorkshire region, and then started working at the Aga Khan University. So we welcome him, and his words of wisdom and his experience will help the listeners a lot. We begin with the scientific proceedings with the first speaker, and that is Dr. Sharif Hashmani from Pakistan. And he has been a founder, patron, and ex-president of Association of Cataract and Refractive Surgery of Pakistan. He is ex-president of Ophthalmological Society of Pakistan and a member of American and APAO Society. He has received President of Pakistan Nobel Christie Medal and APO Gold Medal in Prevention of Blindness, and has numerous papers and publications, and he has numerous awards to his name, and he's the chairman of the Hashmani Group of Hospitals. He'll be discussing with us about multimodal imaging in evaluating post-cataract surgery. So I request Professor Hashmani to share his slides and enlighten us with his talk.
Thank you, Ben. Thank you for introducing me and this nice introduction. Thank to Dr. Ben Limbu for inviting me, and I thank all the organizers also. Now, the purpose of this presentation is to highlight the importance of many minor problems that occur while doing cataract surgery, and we don't consider them as of importance. But I just want to highlight that if these minor problems occur when we are implanting a multifocal lens in, then these minor problems become major. So we have to take into consideration those minor problems also. Number two purpose is to never write off the importance of the patient's complaint. When a patient comes with a complaint, we just write it off. He's psychic, or he's seeing 6x6, and even then he's complaining. So never write off his complaints, and you have to evaluate that patient accordingly. Number three purpose is we are talking in terms of multimodal imaging in retina. Every case we go for evaluation with OCT and OCT angiography and others. Why not in cataract and refractive surgery? So we have to take that modality in cataract and refractive surgery also. So today the world has changed. The patient's expectations has changed. Patient's expectations are all-time high. He's not satisfied with the 6x6 vision, even if he's left with a 0.5 of astigmatism. So because his vision, and 6x6 is it's just a number. It's just a central vision. It doesn't speak of the quality of vision that patient wants to achieve. So we have to think beyond 6x6. 6x6 is just the beginning. So so to make patient happy and to make patient what he wants to achieve, we have to customize the treatment for that patient. We have to customize the treatment for that patient, and to customize the treatment, we need many modalities. Many modalities, and these modalities are like ray tracing, a barometer, the tomography, anterior segment OCT. And all these tools become even more important when we are customizing the treatment for a patient undergoing multifocal IOL implantation. So while implanting a multifocal IOL, we have to take into consideration many things. Like, first of all, we have to look for the tear film. Tear film is the most neglected part. Tear film is the first surface from where the refraction occurs, and then comes the cornea. So tear film health is to be considered. We recently carried out research in Karachi about the tear film, the Karachi ocular surface disease, which is published, and we found that about 43% people are having dry eye. 43.6% people are having a dry eye. The second thing that is most important is we have to take into consideration the health of the cornea. We have to look for if the cornea is healthy in sense of corneal sensitivity or contrast sensitivity. Then operatively we have to look for the rexis. The rexis should be nicely centered on the IOL. And the fourth thing is that centration of IOL should be proper. So to understand that trifocal work, we must know that trifocals work on the principle of light dispersion. So any sort of problem in the cornea, will exaggerate the light dispersion when it reaches the retina, and this will make a patient will make the patient very uncomfortable. Also, his vision for trifocals will not be as good as with the monofocals, and that we have to make him understand that if he wants to see very clear, then he should go for monofocal, and if he wants to compromise a bit for far, then he can go for trifocal. But intermediate and the near vision will not be as good as it is with the glasses. Then we have to counsel the patient before he undergoes the surgery. We have to make him understand that contrast sensitivity will be less than the monofocals, and reading will be dependent on light. He will have to use light for reading, and then he will experience glare and halos. And these glare and halos, he will get used to them. They will not go away. So he must understand that he has to face these problems. Next.
Sir, please share the content, PPT.
Now, with this preamble.
Sir, we cannot see your slides.
Is it okay now? Can you see the slide now?
No, you'll have to share the slides.
Is it okay now?
No, we can't see that.
Sir, we have to click on the share screen button.
Share screen. Yes, yes. Now we can see. Yes, yes. Yeah.
Is it okay now?
Yeah, it's okay.
Okay. So with this preamble, I am presenting just two cases to show that how the patient feels. Now, this is a patient who is a 60-year-old male who was implanted with a multifocal lens, and he was implanted by me, and he was complaining of severe glare. He was complaining the glare was so much that he couldn't see the truck that was coming on, and he could recognize the truck just when it was just a meter away. So he saved his life, and the glare was so compelling that he was very, very unhappy. His refraction, his vision was 6/6 without glasses. His refraction, you can see in both the eyes, is almost normal. And what was the problem then? So we went for an infrared image of the eye trace to see the tear film, and you can see the tear film is absolutely normal. His topography is within normal limits, and then we went for epithelial mapping. The epithelial mapping shows that it's fairly normal, and there is no sign of any dry eye disease. So we went for a theoretical vision on eye trace, and theoretical vision shows that he's seeing almost normal. And then we went for centration of the lens to check the centration of the lens. And you can see that angle alpha and kappa are almost coinciding. So the problem of centration was not there. So we went for higher order aberrations, and you can see that both the eyes' higher order aberrations are almost nil. In the right eye, he has trefoil, but that trefoil is not accounting for the complaint that is making. So what's going on? So now you can see infrared image of the patient. Can you infrared image, and you can see that that there is a contracted part of rexis here, and that part is making that light, a single ray of light, disperse so much. This light is dispersing so much, and since this light is passing through a multifocal lens, the dispersion is manifold, increased. So the patient is not able to see what he's complaining of is suiting this thing. Then we did this was the problem. So we did a yaw capsulotomy, anterior capsulotomy. We cut that part that was coming into while the patient was going into the dark, the pupil gets dilated, and then this dispersion was occurring from here. So with this thing in mind, we did a YAG laser capsulotomy, and the patient's the dispersion of the ray reduced, and the patient's complaints were gone, and he was very happy. So this is a very minor problem. We will never consider this problem as major, and we'll never consider that this can create a problem if this was a monofocal lens. So in multifocal lens, we have to take into consideration that lens edges are lens edges are covered and lens is nicely centered. This we can achieve in femtolaser assisted cataract surgery, and we can achieve this thing with manual also, but we have to be very careful and we have to take into consideration. So the message here is that patient is complaining his vision is 6/6, his refraction is almost normal, but still he's so we don't have to label him as a psychic patient or as a psychological patient, but we have to take into account the multimodal imaging to find out what the problem is. So it was a small ossified rhexis that was causing significant glare. Now, this is the second patient, a 65-year-old patient who was referred to us with a problem for near vision. And she was implanted with a trifocal intraocular lens several months ago. And his vision was 6/6 and 6/12 in left eye. In the left eye, you can see he has got a +1 sphere and -2 cylinder. So where this -2 cylinder came from, either it was present beforehand, preoperatively. If this was present preoperatively, the surgeon should not have done the multifocal intraocular implantation in this case. And if it is, and what about this +1? The +1 spherical number, where did it come from? Is it due to the miscalculation? So we asked the patient whether he has undergone any sort of surgery on the cornea. He said no. We asked him precisely whether he has undergone LASIK surgery. He said no. So we have to go for the multimodal imaging, and we went for epithelial mapping, and you can see the epithelial hyperplasia in both the eyes. These epithelial hyperplasia could be due to the dry eye, but the infrared image of the placido disc based topography shows there is no dry eye. So, and the theoretical vision with the eye trace, we found that there is some problem in right eye of the cornea. The lens, the central vision is through the lens. The first on the left side is this is through the cornea, and this is the whole eye vision. So whole eye vision is almost as same as the corneal vision, and we can't blame the lens. The left eye also, the lens is absolutely normal, but whatever he's seeing with the lens, with the cornea, he's seeing with the whole eye. So there is some problem in the cornea. So we went for topography. The sagittal images show that there's flattening there. The anterior elevation map also shows there's flattening there. And this tachymetric map shows there is concentric rings pattern. This concentric ring pattern shows that he might have undergone some sort of LASIK. We again went and asked him, has he undergone LASIK? He said no. So the similar thing we found in the left eye. The sagittal map shows flattening, anterior elevation map shows flattening, and pachymetric map shows that concentric rings. So we are unsure of diagnosis. Either it is keratoconus, or it is post-refractive surgery, or is it an irregular cornea. So we went for anterior segment OCT, and this solved the problem. You can see there's a flap, meniscus type flap there, and this is a microperitome LASIK, and there is an undulation on the stroma. So this patient had undergone LASIK, and the blade that was used might not be of fine quality. This blade may be used for many patients. So the smoothness, the finesse that should come here. So these undulate, and then it was laser ablated. So these undulations, are responsible for the hypertrophy or hyperplasia of the epithelium that we see there. So this undulating is indicating that an improper ablation during LASIK surgery was done, and this led to the epithelial hyperplasia. Similar finding was found in the left eye, the undulations and these undulations in the stroma, and you can see the microperitome based there. So the hyperopic error that occurred could be due to the improper IOL calculation and irregular cornea due to irregular laser ablation. In the right eye, irregular cornea due to improper laser ablations. So this is just to highlight that minor problems can cause these major problems, and we have to consider every patient very. We have to pay heed to the problems that the patient is facing. Thank you very much. Thank you all the organizers, and thank you all the speakers. Thank you very much.
Thank you, sir. It was a wonderful presentation, and how well you have shown that how technology, the current technology, can be used to unravel things which are sometimes not very clear just by routine methodology. And a patient with 6/6 vision can also have aberrations, can have problems, and can have complaints. And sometimes you don't realize that the patient doesn't give you proper history, but then with modern technology, you can unravel many things. I will request the panelists for this talk, Professor Namrata Sharma, to make her comments on this topic.
I think very nicely illustrated two cases in which it was shown that how imaging can help to solve a problem, and both the cases had excellent documentation. The first case, which clearly showed that one should be careful while doing the multifocal intraocular lens implantation, and how the edge of the capsulorhexis itself can cause dysphotopsia like picture, and when you take care of it, how it becomes all right. And especially in those cases where there is astigmatism present and you want to do multifocal lens. So I think it is very important that you do a multifocal toric lens, because with multifocality, the toricity goes for a 6. And so even small amounts of astigmatism should be addressed. And the second case again was again very nice, and the fact that the cornea was flat between 38 and 41 diopters, and the fact that it was already suspected that some kind of refractive surgery procedure has been undertaken, and that gave a clue also again through the imaging that there was some epithelial hyperplasia. The pictures of the high definition rare society were also very nice, showing the microkeratome flap. So I would just like to congratulate for this wonderful presentation. Both the cases very lucidly presented, and very simple solutions, something that we overlook. So congratulations, and I have otherwise no other comments. Another important thing which was very well highlighted was that probably this was not taken into consideration when IOL power was being calculated for these patients. So one has to be very careful when you are doing a post-refractive surgery IOL power calculation. So that is also something which needs to be seen. Otherwise, you can have surprises.
Thank you, Dr. Namrata. And we move on to the next speaker now. The next speaker is a very popular person, a very dear friend, Dr. Shams Noman. Moving. Yeah. We have Dr. Shams Noman, who is a consultant and head of glaucoma department at Chittagong Eye Infirmary and Training Complex, Chittagong, Bangladesh. And he has done his fellowship from Lalit Eye Institute and Yale University, USA. He has numerous awards, which includes Mubarak Ali Memorial Award for the best glaucoma paper in National Ophthalmic Congress, Professor M.A. Martin Gold Medal, Professor Harun Memorial Award. He is very active in academics. He has numerous, many papers and videos in conferences. He has publications in relation to the eye awareness in different national newsletters. So he's a very active ophthalmologist, very active academician, very much into webinars as well. And so he will be sharing with us about cataract surgery in hypermature cataract. So let's hear Dr. Noman. And I'll just request all the speakers to be on time. The talk time is 10 minutes and the discussion time is 5 minutes. Dr. Noman, please.
So am I audible?
Yes.
Yes. Thank you. It's my immense pleasure to be here with you. The Honorable President, Honorable Chief Guest, and Honorable my fellow speakers, and Honorable teachers. Welcome to the presentation of the SAARC Academy of Ophthalmology. It's a great opportunity for me to be here. And my topic is management of hypermature cataract. And there's a little correction. Actually, now I am an associate professor of Bangabandhu Sheikh Mujib Medical University. I have just transferred from my previous institution. Thank you for the nice introduction. So actually, my presentation topic is management of hypermature cataract. In this SAARC region, there are a lot of hypermature cataracts. So some region we are doing SICS, some region. My slide is visible?
Yeah, now, yeah, it's visible.
So in this subcontinent, the hypermature cataract is more common, and in some cases we are doing the manual implantation cataract surgery. In some region we are doing the phaco surgery. It depends on the patient. It depends on the economy, a lot of things. And I want to show my experience in different situations of hypermature cataract. So in my first case, I want to show a video, a phaco in the white soft cataract. This is a case of Fuchs uveitis syndrome, unilateral cataract, and it's a very soft cataract. So sometimes it's a very challenging for us to make a capsulorhexis. And the most important thing is it is very much important to do cataract surgery, and we have to reduce the inflammation. As it is a very soft cataract, so low power phaco is very much important, and good centration of intraocular lens, and also postoperatively the inflammation control is also very much important. So it's the unilateral soft cataracts, folks. The problem is the asymptomatic and white uveitis. Sometimes it is not kept in mind that the patient have an uveitis. So you have to do the B scan to see the posterior portion of the eye. You have to reduce the inflammation and do the surgery. And this is a case of phaco in the white hard cataract. In that case, sometimes for the beginners, it is very much tough to do the capsulorhexis, and it is in my experiences, I do the direct chop technique, and sometimes it is very much important to take care of the geniole and with the less stress. So the most important thing is that take care of the endothelium if it is an old aged person. So sometimes I have some experiences if there is any low endothelial count. In that cases, even you have to exclude the phaco surgery, better to do the manual small incision cataract surgery. less stress during sculpting, good fragmentation is very much important. We have to take care of the geniole. It's a case of traumatic cataract. When I started the surgery, there is a history of trauma. That was a soft cataract. But when I started the surgery, I saw the lens is moving here and there. Then I started phaco surgery, but still there are almost 90-degree geniular dialysis here. Then I'm putting CTR ring very carefully. In that case, we have to put in a such way that it should be goes within the capsule. Sometimes it should not be go beyond the capsule, and it may create another problem. Done. And so careful CCC is very much important in such case, and less stress, as there is also already geniular dialysis. Direct chop is my preferable technique. You have to take care of the geniule, and you have to use, if need, we have to use the capsular tension ring. This is a very interesting case. That was a case of traumatic cataract with phacomorphic glaucoma. And I tried phaco, but it was not possible for me. There was the space in the anterior chamber. And then I started manual small incision cataract surgery with good capsular exit. Still, the lens is very hard, and the nucleus almost grade 4. In that case, I had to struggle, and then I have to remove. I removed the nucleus successfully. But as this is a traumatic cataract and a significant amount of geniular dialysis, I put the capsular tension ring here, and I implanted intraocular lens. Perfect. And so what is the we have to take care. The subluxation can be associated with the pupil block. In that case, intraocular pressure may be increased. Preoperative intraocular pressure reduction is very much important. Even you have to give hyperosmotic agent. My prefer better to do the manual small incision cataract surgery. We have to take care of the endothelium and genular care. This is one of my surgery, a Morganian cataract. I didn't do the phaco surgery in that case. I just did the manual small incision cataract surgery, and I punctured the capsule and removed the cortex first, and then just inflate the capsular bag with viscoelastic substance. Then I didn't do any hydrodissection or delineation here. I just separate the nucleus from the capsule with viscoelastic and remove the nucleus. In that case, we have to take care of the geniole also. And this is another case of hypermature cataract, and in that case, the phaco surgery was done, and this is a hard cataract, and also there is some liquefied cortex here, and the calcified cortex, calcified capsule is here. In such case, we can do the phaco surgery with a good capsulorhexis, but it was a case of shallow anterior chamber, and it was almost grade 4 nuclear sclerosis. It was really very much tough to do the phacoemulsification. And in that case, actually the experience in the postoperatively, the vision was not very good because as it was a hard cataract, a lot of power was given and some endothelial touch was done. In such cases, this is my experience in this subcontinent, especially in the Bangladesh, in some poor population, it is better to do the manual small incision cataract surgery. It's another case of post-vitrectomized cataract. In that case, and also it was very tenacious cataract. There is very, it was really tough to make segment within the nucleus, and I did it. And one important thing is that this is a post-vitrectomized eye. In that cases, we have to maintain the bottle height, and we have to lower the bottle height. And also most important thing is associated pre-existing PC rent can be associated. In that cases, we have to take care of that portion only. And after that, the vitreoretinal opinions is very much important. So this is another case of phaco-induced hard cataract. I did a very small capsulorhexis here, but in that cases, there is a tag here, and I just removed this tag with the visco removal and with the visco expression, and it was a very hard cataract, and I made it a 4 quadrant, and gradually I just emulsified the whole nucleus. IOL was implanted. So what is hypermature cataract? We know that by the definition of American Academy of Ophthalmology, the hand movement of PL vision, intraocular pressure, normal or increased. Capsule, it can be thinning, thickening, or calcification. Cortex can be leaked, liquefied, or absorbed. Nucleus hardening or sinking. And posterior capsule, it can be thinned or it may be leaked. Some posterior lens cortex can be leaked in the vitreous, and zonule can be weak or subluxated. And it is better to see the intraocular pressure. I used to see the intraocular pressure in every hypermature cataract to exclude any lens-induced glaucoma. I used to do the B scan. I have to take care of the subluxation, whether it is associated or not. If there is raised intraocular pressure, obviously we have to start the anti-glaucoma medication. If it is an unilateral cataract, no history of trauma, and some KPs, old KPs, or even in the KPs can come and go and never pigmented. So in that cases, we have to exclude the Fuchs uveitis in a young age group. And in that case, if preoperative steroid, we have to give. This is our study of hypermature cataract. In that, this is our experience that in the hypermature cataract, 20% of patients have intraocular pressure more than 20 millimeter of mercury, and they have a compromised visual outcome of almost 20% cases. So what are the challenges? Like challenges of creation of capsulorhexis. Intralenticular pressure is a challenge in case of hypermature cataract. Poor or lack of reflex. Cortex in the anterior chamber or posterior chamber, and also weak zonules, that I have already told. So this is very much important to improve the surgical view, like dim operational room light. I don't used to do it. Microscopic magnification will help. Sometimes coaxial illumination will help. Triple blue obviously help. And in some cases, we don't do any hydrodissection if it is a hypermature Morganian. But viscose and also when we do the nucleus management, I prefer the direct chop technique. In case of uncontrolled capsular tear reduction, we can do the 1 stage, we can do the 2 stage, but I do prefer the 1 stage procedure, and I am not very much comfortable with the 2 stage procedure because to me, in the 2 stage procedure, I had experience of capsular extension here. And this is one of my experience. I did the cataract surgery. Even after cataract surgery, there is some capsule vitreous opacity behind the lens in the operation theater. And what I'm telling that the post-operative, post-cataract surgery, cataract formation, it looks like that. And the beginners usually try to remove this cortex, and in that cases they do the post PCTR. But in my experience, it usually automatically it just removes in time with a good amount of steroid. So there are a lot of debates and a lot of publications about the whether phacoemulsification versus manual small incision cataract surgery for the white cataract. So there are a lot of articles here, and the conclusion is both techniques achieve the excellent visual outcomes with low complications rate, because manually small incision cataract surgery is significantly faster, less expensive, and less technology dependent than phacoemulsification. It may be a more appropriate technique in eyes with mature cataract in a developing world. So in some case, somebody told that manual small incision cataract surgery have a safe technique for that, for this subcontinent. And also we can do the phaco surgery too. So we have to calculate our confidence. This is a matter of surgeon's confidence and surgeon commitment towards patient. We have to take care of the economy of the patient, and we have to take care whether it is small incision cataract surgery, whether it is phaco surgery. we have to take care of the outcome, and it totally depends on surgeon's limit. So we have to take care everything because vision's factor. Thank you, everybody. Thank you for the opportunity and patient hearing. Thank you.
Thank you, Dr. Noman. It was a very nicely concluded, uh, presentation that yes, we have to. Can you just unshare your slide? It is actually multifactorial. There are so many factors that are related to a successful outcome of cataract procedure in a hypermature cataract. And for this, we would like to have the opinion of Professor Govind Podial regarding how we should handle hypermature cataract and what is his opinion on this issue and his own viewpoints. Professor Govind Podial, sir, please.
Thank you, Professor Rajesh. It was a nice. Can you hear me?
Yeah. Now we
Yes,
can.
sir.
Yeah.
It was a nice presentation by the moment, and I really liked the presentation. And this
Maybe a
time,
little louder, sir.
yeah, at this time, it is very relevant. After the time of this pandemic, so we'll be getting more and more mature and hyper mature cataract. That is what we will be expecting in near future. So though we are in this conference, we are expecting the cataract, what next, but this is very, very relevant topic, thanks to the organizers. So he has mentioned very rightly the difficult steps and what difficulty we will face, doing a hypermature cataract. And you know that, as Professor Azad just mentioned, that we are in a sea of cataract. And this will be more and more problem, and we will see in future, in near future, few more months. So he mentioned that the difficult steps like CCC, they will be difficult, but yes, shown us very nice videos and most applications yet with FACO. And he also mentioned that maybe SICS is easier. Here, I would like to mention that in really Moriangian cataract were very niche capsule and jonular dehiscence maybe. We find it sometimes very easy if we put lens before you deliver the nucleus, the small, hard, the cataract nucleus. That would be a suggestion. And otherwise, you have done very well. And congratulations. Thank you.
Thank you, sir.
Thank you, sir, for the very nice and encouraging comments. And it was indeed a very good presentation by Dr. Noman. And next, we move on to another presentation by another young and dynamic ophthalmologist from this region, and that is Dr. Shamli Jafar, who completed her MBBS in the year 2003 from the Institute of Medical Sciences, Santa Clara, Cuba. She did her MD Ophthalmology in 2009 from B.P. Koirala Institute and Tilganga University. And she did her FICO training from Himalaya Eye Hospital, Pokhara, in the year 2012. Apart from ophthalmology, she is also interested in diving medicine. I mean, she has done diploma of diving medicine, and rightly so, because she is from Maldives, a beautiful place wherein people go to do diving, etc. Then she became consultant ophthalmologist in IGMH, and she is in 2000. In the year, I'm sorry. in the year 2009, and she's working till date. And currently, she is the Vice President of the Maldives Ophthalmological Society. And she will be presenting to us how she manages cataract in Maldives. So let's listen to Dr. Shamli, how she manages cataracts in Maldives. Dr. Shamli, please. So Shamli, can you unmute yourself and share the slides? Yeah.
Thank you. This is, I hope you can see my slides.
Yeah, just make it full screen. Make it slideshow.
Slideshow, how do that?
No, just go down and you have this, yes, this one, yes, click that. No, the one, okay, that's fine.
Okay. Good evening, and thank you for the organizers to giving me the opportunity to present in this webinar. I'm going to be talking about cataract management in the Maldives, mostly in the government sector. Maldives is a group of islands in the Indian Ocean. It's, as you can see from the slide, is south of India as well as Sri Lanka, and it's made up of a group of islands, about 200 of which are inhabited. And you can also see the capital Malla in the picture, which is very crowded. There are around 200 inhabited islands in Maldives, and the usual population per island is about 2,000 to 5,000. The total population is 500,000 or 5 lakhs, about 1/4 of which are concentrated in the capital. There is universal insurance by the government, so most eye treatments are covered by government insurance. But most of the eye hospitals and eye clinics are centered in the capital. In the islands itself, there are 6 regional hospitals, but there is an ophthalmologist in these regional hospitals, but there is no surgical setup. So if a patient in those islands want to do a cataract surgery, they will have to come to the capital to do the cataract surgery. A RAB study was done in 2017, and it was found that the prevalence of blindness was 2% in above 50-year population, and the leading cause of blindness was cataract. Cataract surgical coverage was 86% in patients with cataract, but the cataract surgical rate was 93.5% in patients who are blind due to cataract. And a curious fact was 41.8% patients received surgery in neighboring countries, not in Maldives, either in Sri Lanka or India. One of the, we'll talk about some important barriers for not getting the surgery done. About 29.7% did not feel the need to do the surgery after getting surgery done in one eye. And sometimes due to patients' general condition, it was difficult for them to travel from one island to another, and they preferred not to do the surgery. And treatment was deferred in 33.3% of patients, most of the time due to no helper being available. The fact is, in the islands, most of the smaller communities, the younger working age group migrates to the capital or to tourist resorts to work. So the elderly and the young stays back. So for these patients to do a surgery, they need a helper to travel from one island to the capital. So till a helper or relative becomes available, they tend to wait to do the surgery. And other social and financial issues, for example, stay in the capital is quite expensive. And financial issues, because in government hospitals, the wait for an appointment can be a bit long, but in private institutions, there is no such waiting line, but government insurance scheme does not cover the costs fully. And weather is an important barrier, because when the seas are rough, travel is very difficult. Excess in treatment. Patient has a choice to get surgery done in private or in a government institution. As I said, in private it is fast, but it is expensive because the cost is not fully covered. In government hospitals, the cost is covered, but there is a longer wait in line. But as after the patient gets an appointment, there is no such thing as a cataract surgical backlog. The method of surgery most of the time depends on the surgeon. ECC is rare, but it is still done. SICS is still more common, and phacoemulsification is relatively rare, new. We don't do multifocal IOLs, and we don't have femtosecond laser cataract surgery. So barriers for surgery in Maldives, from the patient's point of view, the cost of stay in the capital, and another thing is we don't have specialists like surgical retina, corneal specialists yet. All of us are general ophthalmologists. So there is a difficulty in managing complications. So before surgery, we do explain to the patient that in case of a lens drop or in case of corneal edema where the patient may need DSEC, we have to refer them abroad to either India or Sri Lanka to get to solve their complication. So the patient sometimes prefers to go to a higher center to do the surgery in a neighboring country without doing the surgery in Maldives. Barriers for surgery from the doctor's point of view is although there are enough ophthalmologists for the population, a lot of ophthalmologists don't practice ophthalmology. And also there's a lack of ophthalmic assistants, technicians, optometrists, ophthalmic nurses. So due to this, the cataract surgeon has to do the counseling, has to do the biometry, the pre-surgical evaluation. Everything has to be done by the surgeon himself, which is not really, it's time consuming, and also a lot of counseling is needed sometimes. Additional training is also needed because due to the fewer number of cases, because the population is small, we don't do a lot of surgeries. So due to this, if, for example, someone who is finishing their residency is not very comfortable in doing surgery, it takes a long time for them to get confident because the numbers are small. And also since we don't have a lot of seniors here, if there is a complication, most of the time we have to manage it ourselves, or we have to refer the patient to India or Sri Lanka for further treatment. So due to that, we have the tendency to not try to do complicated cases. And there is also difficulty in getting hands-on training in neighboring countries. And I also find that compared to about 10 years ago, the recent graduates have less hands-on training. Also, there is a lack of equipment and machinery. For example, corneal and retinal setups are not present. So some curious findings that I have come across is that female patients, for example, are more happier with myopic errors after surgery than with hyperopic errors or even zero refractive error. I think because we do come into contact with them for longer before surgery, and as biometry and everything is done by us, we tend to talk to the patient more. And most of the ladies above 65 years, for example, tend to be retired patients who stay at home, who read a lot, and who do housework. So their near vision is more important to them than their distance vision, and they are happier to not have to wear presbyopic glasses to do their work, and they are used to putting on sunglasses or photochromatic glasses when they go out of the house. So for them, it is more comfortable to not wear glasses at home than for them not to have the need to wear glasses when they go out. And dry eyes or foreign body sensation after surgery is very common. So sometimes you have to give tear supplements for 6 months or 1 year after surgery. When I first graduated, I used to do SICS without suturing, and I used to get, like, after 6 weeks when they come for refraction, some patients used to have iris prolapse. So after that, I started suturing in SICS, and I find it helps. And even after long follow-up, the astigmatism is not so much more, and they tend to have fewer complications. And also, my personal finding is that an astigmatism at 90 degrees of -2 or -3 actually helps, because that also makes them, the need for glasses not that important. And another point is outcome is more important than method of surgery. So if someone is quite confident in doing ECCE and they're getting a good result with ECCE, and the patient is happy with the results that the surgeon is getting with ECCs, it is more more helpful to continue with that until the surgeon is more confident in another more advanced technique than to try to go into modern techniques initially. Choose the method the surgeon is most comfortable with. Thank you.
Thank you, Dr. Shamli. It was very nicely presented, and your statement that was written in the last slide, that outcome is more important than the method, that is very apt, very correct, because you can have various methods, but it's the outcome that matters the most as far as the patient is concerned, and even for the surgeon, that makes the surgeon confident. Thank you very much. For this, I would like to have the opinion of our panelist, Dr. Irfan Jiva, to please comment on what he thinks on what Dr. Shamli presented, and a beautiful place like Maldives, wherein we have some limitations at this point of time, but definitely with time, there will be more and more specialists, working there and improving the outcomes as well as the quality of care given by ophthalmologists. Dr. Irfan Jiva, please. Dr. Irfan, are you there?
Yes, I'm right here. I'm so sorry. I'm just struggling with the internet a bit. My apologies for that. Yeah. Firstly, thank you very much for this wonderful presentation. It actually brought back memories of the time when I was in the process of developing something similar in Kabul and in Jamaica. And my experience is not too dissimilar from what we just heard right now. The challenges of human resources and technical resources are real. However, what I see is that the work that they are doing is amazing, and I think we as a world community should help develop it even further. Things like extra cap can certainly be developed in a place like Maldives, because it's really not that difficult, and I think a platform like this could be very useful in gathering like-minded people together to help hopefully develop a better program. But overall, thank you very much for a lovely presentation.
Thank you, Dr. Irfan, and thank you, Dr. Shamli. Now, I would request Dr. Ellie to take over and give the introduction of the next presenter.
Am I audible? I'm not audible.
Yeah, you're audible. Yeah.
Okay. So no, I'm really delighted to introduce Professor. Let me just go to respected Professor Dr. Sandakruit. He is definitely a visionary and dynamic leader of the world, I should say. He's Professor of Ophthalmology in Tilganga Institute of Ophthalmology and Executive Director and of IMN. He's International Director of International Federation of Tissue and Eye Banks. He is co-director for Himalayan Cataract Project. And he has multiple awards, to name it, like Suprasiddha Prabal Janaseva Shri. This is the latest one. He has Prime Minister National Talent Award 2019. He has been bestowed with Padma Shri, the greatest government award of India 2018, Asian Game Changer Award, National Order of Merit Gold by His Majesty the King of Bhutan in 2015, Arthur Lim Award, and there's so many awards, and I'm really privileged to speak on all these. He has, following his post-graduation, he has done fellowship with Professor Fred Hollows from Australia. He has multiple publications and he has co-authored and he delivered good numbers of invited lectures in country and abroad. So I would like to request Professor Sandakruit to speak on, as a special guest oration, on cataract blindness, SAARC and SAARC perspective and looking towards future. Welcome, sir.
Thank you very much, Dr. Eli, and respected teachers and Professor Malla, Professor Azad, my friends, Maipal, Lalit, and many others, Namrata, and many others who are listening to this, important interaction on cataract in the SAARC region. What I might like to do is I will talk a little bit about the SAARC perspective and demonstrate to you Nepal as a case study, and then discuss a lot about in the operating theater and outside the operating theater, the logistic issues. And at this time, I'd like to thank all my team back in Tilganga and everybody who's involved with the prevention of blindness program in Nepal, especially our colleagues who are working with Nepal Nitra Jyoti Sangh and many others in Nepal. And if you talk about global facts, we all know that more than 89% of the visual impaired vision lives in either low income or middle income countries. And cataract continues to be, like we discussed, the most important cause of blindness. Cataract continues to be the most important cause of blindness. And if you look at a point where I believe that people with very advanced cataracts, especially the ones we call as 3/60 cataracts, are cocooned inside. And people with better vision with cataracts seek services earlier than the ones with poorer vision. And the ones with advanced cataracts, unfortunately, are more deprived socially and economically. And they're often unreached due to geographical sequestration and many other amenities. And I like to, sort of discuss this with our colleagues here. And the term that I like to use is operable cataract, the type of cataract that we operate. And we all know that nowadays the results are so predictable that we often do cataracts closer to 6/9. And I think number of surgeries of cataract is not equivalent, it's not equal to the number of blind cataracts. So basically, if you look at this segment that I'm trying to explain to you,
so we need to have your slides.
Screen share. Yeah, you got the slides there? Yeah.
Yes.
And if you look at this, proportion of patients, it's not a very accurate number. It's very difficult to find out, but I would believe that number of patients with 3/60, if there are about 13 million, and there's another 65 million with moderately severe visually impaired, but that's 6/18 or worst. And then quite a bit of cataract that a lot of people like us like to do now is between 6/18 and 6/9. And if we say that about 25 million cataracts are done every year, then we still have a great number of backlog, which is about 73 million. But these are not accurate figures. I'm just trying to segment you and tell you that what operable cataract is all about. Yeah. Now, if we try to look at the scenario in the SAARC region, that's what we are meeting here. And I think the, we all know that the population of the SAARC region is about close to 21 to 22% of the world population, very close to 1/4 of the global population, which is significant. And if you look at the prevalence of blindness, you see a lot of differences. And if you also look at the proportion of the cataract blindness is more or less around 50 to 60%. And the cataract surgical rate, there's a myriad of differences from 500 to about a little more than 5,000. So there's quite a bit of inequity there between countries and inside the countries too. And this is something that I wanted to share with you. If you look at the SAARC region, particularly in perspective, the cataract surgery, and I'd like to share with you some of the strengths and the weaknesses that we encounter. And in this region, we have some of the best large successful models, quite a number of them in different countries, but we don't have small successful community models. This is a hard fact, and this is what really needs to be pronounced again and again. And we also know that there are fantastic provisions for manufacture of inventories of consumables and equipments and machines and pharmaceuticals. But again, there's a problem of consistency and the quality of the consumables. So this is one of the weaknesses, I would say. And now, in the last 20 years, human resources training have taken a great leap, and it's really fantastic in all the regions. But however, team building at the community level is still a problem for many reasons. And if you look at the cost recovery scheme, which is why we need to have a business plan, there's lack of sustainable, scalable models. And of course, there are lots of individual strengths, bright side of these in our region, but there is very frankly lack of concrete collaboration, which probably something like SAO can do very well. And I insist that there are fantastic private models and networkings, and they're doing extremely well, delivering state-of-the-art, world-class, ophthalmic care. But if you look at the weaknesses, there is tremendous inequity in this region again. So this is just my perspective on the eye care, especially focusing on cataract surgery. Yeah. Now I wanted to sort of share with you a case study on our efforts in the cataract surgery in the last 3 decades in Nepal. And in 1981, we did a very important national survey of prevention of blindness, which was really the landmark for the program following. And this was a multi-strata, multidisciplinary scientific survey, and which very nicely told us the magnitude and the distribution of blindness. And the blindness prevalence at that time in 1980-81 was 0.84, with 80% of avoidable blindness. Interestingly, cataract and sequelae comprised of 83.6% of the avoidable blindness, and as much as 5.5% was iatrogenic blindness because of bad cataract surgery. And very often, about 60% were left without FAK glasses. So virtually, you left behind more than 70% functionally blind with the conventional type of surgery. So the question, to us, we got extremely passionately involved with a mission at that time to have an initiative to provide sufficient in terms of numbers, successful in terms of quality assurance, sustainable in terms of finance and logistics, modern cataract surgery to the community. And this was really our, our main mission. And at that time, we found, by looking at the issues, and I'm taking you way back to the 1980s, and those days, there were no intraocular lenses manufactured, no sutures manufactured, no viscoelastics, found at this region. So cost of the high quality IOLs was one of the biggest factors. They were not available, easily available. They were extremely costly. And the second was adaptation of good surgical technique and system appropriate for the local condition. I mean, if you look at those days, in the mid-80s, we used to get packs, disposable packs with intraocular lens, and a Helan, viscoelastic. Only Helan was the only one that was manufactured. And very often, intracameral myocol, acetylcholine was part of the surgery, and then sutures. And the whole pack used to cost a lot of money, thousands of dollars. So it was out of the boundaries of poor people here in this part of the world to have this type of surgery. And of course, the cost and complexity of the equipment. So these were the, we fragmented, studied the barriers. And early on, we started fighting, trying to do microsurgery in the very moderate, modest fashion. And microscopes were very expensive. They were at that time more than $50,000. So we started saying whether we could use the laboratory optics microscopes and then have some very well-focused side lamp and trying to have a pseudo-coaxial illumination and operate and do some extra cap surgeries. And it was possible in very wide cataracts. It was possible, but we had to rotate the eye, try to get a ray reflex. And so it's not all that easy. And that was what, and so see, this is another cases where we did lots of pilot study in different parts of Nepal in the mid-80s and late 80s. And those days, surgery was without gloves. And so in 1991, we published the very first results, long-term results of more than 2 years of extra cap with IOL. And this was published in the Archives of Ophthalmology. And this incited lots of international debate. A lot of our colleagues, thought that maybe it's not the right time to do it. And colleagues from this part, from developed part, so there were a lot of debates in this. And it was probably the first time that we propagated the uses of posterior chamber intraocular lenses and microsurgery in the field. And very first time to use ambulatory surgery as a routine. And those days, ambulatory surgery was not part of the cataract surgery. So The adaptation of the good quality surgical technique took us nearly 5 years. We simplified, adapted, and tested. And the training, once it was fine-tuned, the training program became extremely, it became popular and went globally. We started producing standard operating procedure manuals. And on the platform of the Fred Hollows Foundation Himalayan Cataract Project, it went all around the world. The manufacture of intraocular lenses in Nepal started in mid-90s, and side by side about the same time as Oral Lab started manufacturing, and we were able to manufacture extremely high quality intraocular lenses of CE mark for affordable cost. Until now, we have distributed more than 6 million IOLs around the world. And as with the process of evolution of the cataract surgery, and we started thinking about modifying the small incision cataract surgery, which was performed by our friend, in Jerusalem, and he used to call it as mini nucleus extraction, and then deliver the nucleus with a sheath glide, and we actually modified it so that it was adaptable to a high volume use in a condition like ours, and started calling it as a manual small incision cataract surgery. And we found that it was simple, low cost, good outcome, but still got lots of criticism in the beginning. I remember the days when I was giving instruction course at the American Academy of Ophthalmology. The first year I gave instruction courses, there were about 10 to 15 who were on the class. The second year, probably about 50. The third year, there were about 400 people. They had to shift the lecture to a plenary section. So then, we were able to convince people that this is a good modality of surgical technique. And so it was important for us to do the first randomized clinical trial comparing small incision cataract surgery with the phacoemulsification. And we invited the best of the best, David Chang, to come over, and David Chang and I did the randomized clinical trial, and we looked at the results for 1 year, and he started using the high-end JEISS microscope and the White Star, and I was using a simple portable microscope. The capital and the running costs of phaco was about 20 times higher than the small incision surgery. And the results immediately 1 month and 1 year were really not bad. And I'd like to show this. This is a photograph taken by a friend of mine who's a professional, world-renowned photographer on the steps of small incision cataract surgery, the wound construction, capsulotomy, and nucleus delivery, and then the lens implantation. I love the color of this slide. And if you look at the results, we found that at the end of 1 year, uncorrected visual acuity were comparable in the two techniques. And now coming back to cataract surgery, we all know that it's fairly straightforward, extremely predictable. You can predict uncorrected vision. You can have quality assured. But when you take this surgery to community, there's a different challenge. And this is what I'm here to discuss about. So if you look at the cataract surgery in the community, it becomes not surgery, but it becomes a delivery system. That's what I always like to call it, because it compasses so many things. And we have to look at the team building. We have to look at social marketing, screening, diagnosis. We have to look at different stations, quality assurances, and governance, partnership, medical insurance. I'll talk more about it later on. And, again, team mobilization is very important. Job description, 2 ophthalmologists and about 10, very well 10 paramedics. That's the ratio. Inventory and procurement, extremely important if you're working at the community level. Financial management, quality assurance, partnership, public, private, and social. And very important, the commitment, culture, and passion of the staffs working. And this is an integrated workstation that I would like to demonstrate to you, starting from promotion and social marketing, diagnosis and screening, transportation to the venue, surgery itself, investigation and biometry, very important part, anesthesia, surgery itself, surgical technique, these all become part of the station, and post-op examination and follow-up and monitoring. And everything is documented extremely well. Now, let me share with you the cataract surgical rate in Nepal over the period of years. Since 1994, we had about 500 per million per year. And now it's almost 5,000 in 2018 and close to 19 now. It has been a gradual increment of the cataract surgical rate. But if we include some of the patients coming from our friendly countries, our cataract surgery rate actually becomes more than 6,000. And if you look at this slide, this is just to compare the spike in the cataract surgical rate between the two techniques. The technique of small incision cataract surgery, which gives an initial spike in the CSR. And then, later on, after 2016, the spike in the phacoemulsification. Now they are trying to meet somewhere. And, the reason the first spike, the reason for the first spike and the reason for the phaco to go up, I will try to explain to you. The reason for the initial spike was we were able to organize a great surgical delivery system with fantastic team build-up and very good quality team. This is all important. And then the intraocular lens manufacturer for having the very high quality intraocular lenses affordable and good SICS, but I want to add good quality SICS. It's very important that you say this good quality SICS. And the second spike, that you saw towards 2016 and till now is there's a demand for phaco. And importantly, the availability of medical insurance. Please remember, and I think many of our colleagues in other parts of SAARC region can accelerate the use of medical insurance. It'll make our life much easier. And thus, the system that we had delivered, we wanted to share, there was a demand to share in other countries, and we have tried to share it in many other countries in Asia, Africa, and sometimes in South America. Indonesia, part of the large cataract workshops where we try to share all the, all the things that I've been trying to describe, and training of both surgeons and the support group. In each workshop, 20 to 40 ophthalmologists are trained. Nearly 40 support staffs have been trained. This is in Myanmar. This is in Africa. Now, looking at the future, I would still consider a very good quality temporal SICS and manual with good results. Proper training would be useful for at least few years. By and large, there is no confusion that phacoemulsification with foldable lenses is the treatment of choice. There's no doubt about this, but with good results, but you should look at the cost factor. The training is very important. The equipment is very important. It's important to have support staff looking after the equipments. Now, when we talk about phaco in community, lowering the cost shouldn't compromise the quality of the machine. The machine, I would like it to be user-friendly machine, and there should be a lower consumable cost. Intensive and standardized training programs. It should address large target groups as the SICS is trying to address now, can address. And very often we need a vitreoretinal backup. That's a reality. And what's really important now in this community cataract surgical delivery process is it's important that we have good governance. It's very important to retain committed people. And I've been working in all these countries. One of the biggest problems is retaining good team. And to retain good team, it's important that they should be given good salary. They should be given good incentives, ownership, and authority. I think this should be part of the process in building up a sustainable model. And trained in good quality team, again, standard operating procedures, quality assurance, pricing tier for cost recovery. Now, a little bit about, about post-COVID. It's such a, it's very difficult to discuss about this situation right now. All of us know, but it has produced a big paradigm shift in our lifestyle. And it has also produced a paradigm shift in the treatment of prevention of blindness. And we have seen that there is a tremendous decrease in the volume of eye care and thereby producing an increase in the cost, especially eye care, where lots of the services provided by NGOs, where we're looking at cost recovery as one of the important financing factors for meeting the operating costs. And field activities have been reduced, disruption in the supply chain, limited globalization, social distancing, and other COVID issues. So it has become very important for us to redefine our protocols, especially at the community level. And we are constantly looking for models. And one of the models that we have been practicing, I'd like to share with you, which will become very easy for us to deliver high quality cataract at the community. That's where it is necessary to address the large blinding population. And if you look at the structure of the eye care, I would say this is for a population of 40 million unit. You have 1 or 2 centers of excellence, about 5 to 6 regional eye centers, and you should have about 25 community eye hospitals. This should be the basis of the quality, sustainable quality care. And then small community eye centers or vision centers of about 70 to 80. That's like a unit that I would, think. Now, the community eye hospital should be achievable, autonomous, sustainable, should deliver high quality community, should be a scalable models, 3 to 4 floors, $2.5 to $3 million costing in capital, infrastructure, equipment, first 3 years of running cost. And the concept is it delivers very high quality cataract surgery, both SICS and phaco. And it also gives smart refractive error programs, including the optical dispensing. The whole chain of doing refraction and providing optical dispensing of good quality is very important for cost recovery. And at the same time, it can also provide medical retina, glaucoma, diabetic retinopathy, and periodical subspecialty training, community screening. But quality cataract surgery is at the heart of it. We have some, this is one model in China, in Xining, and this is one in Nepal, which is very successful in a population of very low paying capacity, but we are still meeting the operating cost and delivering very high quality eye care at the grassroots level. This is in Kalimpong and northeastern India, and which also does in a small scale, but very high quality, sustainable, and good quality cataract and some retinal services. And compliance, I would like to, governance is very important. Health personnel job description, health financing. Again, medical insurance is very important. Medical audit and management information systems are very important to have sustainable, high quality service delivery. And, after this, I'll play a short video, but I really like to pass to each of you at this moment. Pass through the most challenging period of our lives. I sincerely request and urge all of you to share lots of compassion, love, and empathy for our fellow human beings. I'm sure all of us are going to be a little different from, what we were before this, before this thing happened. So I really urge all of you to have lots of compassion, love, and empathy for fellow human beings. I'm sure we'll continue to do our good work. Now I'm going to show a small clip of video. This is a cataract, which is in a real sense that we study in textbooks as a hypermature cataract. And I often like to call this as a vanilla chocolate ice cream. Half is really brown and half is a little white. And also had suffered phacomorphic glaucoma with circumcorneal congestion. And this is a patient that I encountered in Indonesia, coming from a place called Aceh. And this is a fisherman who had lost one eye with a fish hook, and this was the only eye on a 59-year-old looking after maybe 7 or 8 family members. And, what is the treatment for this? So my concept is we should do what is best for the patient. And it's very important to look at the background of the patient. So we do a technique that is best for the patient. I'll play the video and this is in true sense a book picture of hypermature cataract with very large ballooned capsule, very weak jonules, and very flimsy capsules. And if you try to do an extra cap, you very often take the whole thing out. And so we're doing and the nucleus is button-like hard. You can't fake them. So I'm just dissecting the capsule, and see the balloon of the capsule is really big. So what I do in this is something that probably out of the box, and very often if you try to deliver this nucleus, the whole capsule and journals may come out along with it, and you leave the patient aphakic. So we put an intraocular lens before the nucleus is delivered. You can see the nucleus slowly coming into the anterior chamber now, and the capsule's gone back, and you can deliver the nucleus very safely. Yeah. So the whole idea is, is what is really best for the patient. And thank you very much for allowing me to speak in this wonderful forum. And I'd like to thank Professor Malla, Professor Azad, Dr. Ben, and everybody. Thank you very much.
Thank you, sir. Thank you very much for such informative and inspirational talk on cataract blindness, especially on SAARC perspective. Going back to the early days of cataract surgery in Nepal, and as well as challenging services. Of course, we know that your sole mission is to bring eyesight back to anyone who needs it. Thank you very much, sir. With this, we'd like to start the next session. It is a symposium on cataract, what's next? So I would like to request Professor Mahipal Sasdev for the first talk on flags. Before that, I would like to, introduction about him as well. And indeed, I'm again privileged to, it's a privilege to speak on his, Professor Mahipal Sasdev. He's, as Professor Azad said, he must be the dynamic president of All India Ophthalmology Society, with MD and MBBS from AIMS, with fellowship at Georgetown University in Washington, DC. He has more than 100 published articles to his credit. He has been editors to so many journals as well as in the editorial board. He has authored more than 10 books on cataract and refractive surgery. He is, of course, visionary and dynamic leader, chairman and medical director of Center for Sight, and he has been chairman of Scientific Committee of AIOS 1996 to 99, and Indian representative at the Asian Refractive Council. He has been awarded with so many, credits to him. It's like Padma Shri Award in 2007, A.C. Agrawal Memorial Trophy, Colonial Ranagachari Certificate, S.N. Mitter Orison Award, Lifetime Achievement Award, and Gold Medal in Coscan Conference. Welcome, Professor Mahipal Sasdev, to speak on flags. Welcome, sir.
Thank you very much, and good evening, everyone. Pleasure being here at the conference, and thank you very much all the office bearers for having me. I'll be talking about flags, and that is the femtolaser assisted cataract surgery. This has been my passion over the last 7 years, and I think today patients are demanding femtolaser assisted cataract surgery, and we are also having a good outcome. Are my slides visible?
No, sir.
Okay,
You have to share. They were, and then yeah.
Stopped it. I don't know. Anyway.
Yes, sir.
Yes.
Is it all right now?
Yes, sir.
Okay. So today, if I look at my personal current practice, about 70% of the patients who are undergoing cataract surgery are undergoing with the femtolaser assisted cataract surgery. Now, when we look at the femtolaser, we all know that it makes, there is an unnecessary debate, I would say, between phaco versus femto, because I think both of them are complementary. You can't do a femto without a phaco, etc. And what the femto is doing is that it is making the procedure into a refractive procedure. And what that means is that you can get accuracy, precision, and repeatability in anybody's hand. Whatever be the skill set of a doctor, I think this will give repeatability. You can get the capsular access that you want. You want the primary, secondary incisions, and you can get the arcuate incision for correction of small degrees of astigmatism, as also there is softening of the nucleus. So these are the 4 steps, as I told you: capsular access, lens fragmentation, incisions, and arcuate incisions. And all the 5-6 companies who have this normally work with this pattern only, that the first thing that is done is capsular access, followed by lens fragmentation, followed by incisions, and then arcuate. We have done more than, I would say, about 10,000 cases in 6 years and up and counting. We started with the routine lensex, which had certain teething problems. And then after some time, because of the posterior corneal folds that were coming, and there were some skip areas in the capsulotomy, the lensex shifted onto the soft fit. But by far, we have given away the lensex, and our laser of choice is the Catalyst. I am a consultant for J&J, just as a disclaimer, but that is the fastest CCC that we get, and I think it has a good intuitive machine that we can use for femto cataract. Now, I will just be talking about difficult situations that should be there. And I will show you the minimum energy that is used for soft cataracts. And then I will show you that normally it is the difficult situation starting from the hard cataract onwards, which makes the procedure safe and with quick recovery with predictable refractive outcomes. Now I'll just show you the first one, which is in a soft cataract. So you can see that this is the docking on the system catalyst. You take this to the green part, and then you do the capture and lock, and the OCT image is a fantastic image that you can get. So you get an OCT image. This is the interior cornea, this is the posterior cornea, the lens, etc. And it is very intuitive. It says that the incision is intersecting. So therefore you have to do modifications as regards the incision. So you have to bring it because it's going out of the limbus, and you bring it. That's the incision that you can see. This is the primary incision that you are bringing in, as you can see, so that it does not go onto the limbus. Now, this is the pattern. It's a 4 pattern with a softening that has been done in this particular case. And we approve this. And you can see that once you have approved this, capsulotomy is almost just 1 second. And this is the softening and the quadrant, which is about 32 seconds, as you were seeing, which is happening. There is no LRI in this, so it's written not included. Primary and secondary incision will be there. So this gives you the time for the nucleotomy, and this is giving you the total time that is remaining. So you can see a good capsulotomy has come. You can see a good 4 quadrant separation that is happening, plus a softening which is happening. So this is the methodology that is being followed with a liquid optic interface. These air bubbles that came in shows clearly that the capsulotomy would be free, and you are also getting some bubbles which is coming from the primary incision. So you can see this is the primary incision which is there, and now you will see the secondary incision that is coming. So this is the end of part 1 of the procedure. And now just watch this. This is in the OR, and you can see it's a free-floating capsulotomy. Majority of the cases, we do get great capsulotomies with some adhesions which are there, but it's very, very easy to take them off. So this is a free-floating capsulotomy. Now, what I'm just trying to show you is that the softening of the nucleus that has happened and the 4 quadrants that we made, it is actually very, very easy after doing the hydro procedure. You can see that this is just methyl cellulose that is being used. And with this cannula, you can see that we can actually separate out and divide the nucleus into smaller pieces. So obviously this will be a zero phaco surgery, because you can see that we have been able to divide it into 4 pieces very easily. And there is just an aspiration that has to be done, because there is already a lot of nuclear softening that has happened. So just to show you the power of phaco that is there in softish cataract, that is grade 2 nucleus, etc. But let's just look at hard cataract. So if you're looking at hard cataracts, the femto essentially can help in breaking the backbone of the hard cataracts. The only thing is that it should not be totally white. If it is a totally white cataract, then the focusing does not happen, and one is not able to get the cracks. So you can see here that this is a slightly larger capsulotomy. Normally we keep the capsulotomy at 5, but when we have such big cataracts or dense cataracts, we make it to 5.2 to 5.5, because you can get the pieces out. All that I'm trying to show you in this particular case is that if you see here, this is the area where you can see that we are cracking. And just watch here, the crack that is going to come. You can see that there are bubbles that are escaping, and it's easy to crack this lens. So these bubbles show that the cleavage has gone down underneath, and you can see that we can do a good separation right up to the bottom, which is the problem in hard cataract. So I'll just show you the color of the nucleus. You can see that this nucleus is a black cataract. Just watch here. This is a black cataract that is coming out, and you can see that this is the separation that has happened. So you can see we are getting this quadrant. So I'll just fast forward. All that I was trying to show you is that it's in the harder cataract. See the quadrants, the ease with which we can get out the quadrants. You will never be able to get that if you are trying a phacoemulsification. Again, you can see another quadrant, and we will be able to put in the lens pretty well. So hard cataracts are where the maximum amount of energy of phacoemulsification is saved, and you can see that the patient looks much clearer as regards the outcomes of the cornea. Now we can see in fibrotic capsules, you can increase the energy, you can reduce the distance between the spots that are there. And this is the post-traumatic cataract that was done. And this is the opening of the incision, as you can see. In this post-traumatic cataract, right here, you can see that this is a fibrosed area. So you have a capsulotomy that has happened well here. There is a fibrotic tag which is there. So this is a problem. But you have postage stamp openings. So you can again see that these are postage stamp openings, which if you are careful with this, you will get a perfect round capsulotomy. So see that we've been able to get this away because there was already perforations here. But again, you can see in this area, there is the fibrosis which is there. So if we hold it again well, and we are able to again take this capsulotomy completely. So if we were trying to do a capsulotomy in such a fibrotic capsule in a traumatic cataract, we would have used the vanas and we would not have got a perfect capsulorhexis. So capsulorhexis is one of the best things I would see that say that this femtolaser does for us. Now let us look at the capsulotomy possibility in intumescent cataracts. All of us are aware of the Argentinian flag sign. And if you are looking at the Argentinian flag sign, you will not get it in a femto because you are working in a closed chamber. And that is very, very important. But the important thing is that you have to watch for tags always and always remember to stain. So whenever I have an intumescent cataract, the treatment of choice for me today is the femto. So you can see this is a white cataract. I'll just show you the capsulotomy. Just see here, this is a capsulotomy that is happening, and look at the huge intumescence, the fluid cortex that was there, which came out. So let us just see at the end of the time that this is a good capsulotomy that we have got. You can see here, stained with trypan blue, and we get a great capsulotomy. Now just watch, even though there was a lot of fluid in this particular case, there is no runoff. You have got a perfect round capsulotomy. And again, I'll just show you that the nucleus has also worked. You can see that the separation of the nucleus has also been good. Can you see these sections which are there? So we have, despite it being white or brown, there has been a nuclear separation that has happened. You can again see, and we get a good outcome in this particular case. I'll show you another case. This is a patient cardiologist who came to me, I think about 7, 8 years ago. With a phacomorphic glaucoma. So this is a phacomorphic glaucoma. I'll just show you the OCT image, which will clearly show that there is a phacomorphic glaucoma. This is just the centering and all. This is the old LensX system that I used at that particular time. Just watch this. Can you see the iris touching the back of the cornea and the swollen lens which was there? It'll come again. You can see it's a huge swollen lens with water clefts which are there. So this is the LRI that we are doing. In this particular case, we will be implanting, you can see the huge swollen lens. Can you see it, how swollen it is? And the clefts, and just see the capsulotomy and look at the huge bump that is there of the fluid that is coming out. Again, the primary secondary incision, I'll just show you no Argentinian flag sign, no runoff, because you were working, despite this intumescent cataract, phacomorphic glaucoma, you were working in a closed chamber, and you can see that we get a good capsulotomy in this case. Again, you can see that the surgery goes uneventfully, and this is a crystal lens that we implanted in this particular case with good outcomes. Now, another area where I think RP Center, Dr. Namrata is also here. They have also done a lot of work, and we have also done a lot of work. And there are other studies which are coming as regards pre-existing weakness which is there in the posterior capsule, and how the femto helps us. When you are doing a femto, you actually get a pneumodelineation that happens, and it eliminates the need of hydrodissection, hydrodelineation, and it helps you in nuclear disassembly. Mind you, the moment ever since I have switched on to the femto procedure in posterior polar cataracts, we have not had any nuclear drop, because it helps you identify where you are doing the femto procedure, and you are, without any rotation, able to take out the nucleus. So let us just see how this OCT which we are seeing will help us prepare this. So this is the docking that is happening. As you can see very clearly, we have captured it. And you can see here that once we have captured in this particular case, you are locking it. And we will show you the OCT image just now. So this is the OCT which is coming. Just see the OCT. I'll just pause here for a moment. Just see. So this is very clear that this is a pre-existing defect which is there in the posterior capsule. You can see this. This is the pre-existing. There is no capsule that you can see. So 100% sure you are going to get a rupture in this particular case. So when we are doing a femto in this OCT, we will leave behind, say, up to this, which may be about 800 to 1000 microns above the posterior capsule. You can visualize and see, and then do the breaking of the nucleus. So just watch here. We raise the posterior default. Can you see we have raised it further? We have raised it, and we are leaving behind this place. So when we are doing a nuclear disassembly, the posterior rent is taken care of. We don't go near to it at all. So we'll be able to take out the nucleus very well. You can see this is a good capsulotomy, and we will use this capsulotomy to put a 3-piece lens, which we are prepared to. So you can see it's a fantastic capsulotomy. Now I'll just show you that we are not going to do any hydrodissection. We have used no fluid at all. And it is just a pneumodissection that is there. And these are the cut areas which are there of the nuclear pies, and we can just easily take them off. And again, I will show you that the superior part we have removed without any rotation. So you just need to nudge it. The pneumodissection is enough for you to actually have this coming out. Can you see the pneumodissection is enough for you to see it coming out? Again, you can see that we are separating it. Can you see I have just taken out the central part of the nucleus without nudging the epinucleus. And this polar cataract is staring at you to come and cause a posterior rent. So again, you will now need to be a little reasonably fast to remove this, but do not allow the chamber to be decompressed. Put viscoelastic from here with the fluid in, and you can see that now we still haven't got a rent because this cortex is there still preventing. And the moment you remove this last piece of the cortex, you can see that there is a huge defect. You can see that there's a huge defect that has shown. We knew right from the beginning this is a defect that is going to be there, but we have postponed this posterior capsular rupture with no vitreous loss right to the end of the surgery. So this is the power of visualization that you have with the OCT on the femto, which will allow you to come out with great outcomes. So this is a 3-piece lens which we are putting at. It will be reasonably stable and the patient gets good outcome. So this is just to show you, this was the defect. You can see this is the defect. This is the posterior edge that is there, and we can just raise it. On the contrary, if you see this particular case, you can see here that there is no defect per se. So this is a polar cataract where you're not going, and the classification is being done for these particular defects. And these are our papers that has been published in the Journal of Cataract and Refractive Surgery. So this is there is a very high specificity and sensitivity on these, and what we conclude is that the femtosecond laser with integrated ASC anterior segment OCT is a relevant and helpful tool to detect and increase the safety of pre-existing posterior capsular rents that is there. Now, let us just show you again the final presentation, which is in post-traumatic subluxation. The important thing in subluxation is that you do not have a counter traction that is available when there is a subluxation to do a good capsulorhexis. The second is that if vitreous is already coming out, there is going to be a problem. So in this particular case, you will have, this is again a doctor who came to me from Bihar. You can see that this is a subluxation which is there. You will see that this is vitreous which is coming out. I'll just show you. Can you see on the OCT this is, can you see this? This is the vitreous blob that is coming. You can see that this is not attached anywhere. So this is the subluxation which is there. So you can actually change. Now, the other important thing that you can do is that you can try to center the capsulotomy on the capsule center. So that when you are pulled by pulling a ring, there can be the recentration. So again, this is small. It is still cutting the iris. So we are making it smaller, but it is not still going on to this. See this, it is cutting on the iris, which is there. Supposing the pupil was more dilated, then I would have centered it here. So the scanned capsule center is one way, pupil center is the other way, the limbus center is one. So I'm going on to the customized centration now, and we will decenter it to the level which is enough for us and increase the diameter to 5 so that we are not cutting on the pupil which is there. So you can have a capsulotomy. You can see it's a fantastic capsulotomy despite vitreous coming out here. So once we have this capsulotomy, even in case of a subluxated cataract, half your battle is won. And then the next important thing that we are doing is that we are doing the nuclear disassembly, and it will be very, very easy for us to take away the nucleus, which we can take away very well. So you can see here, good capsulotomy without disturbing any problem of the vitreous. So we are going with a pars plana approach, where we are taking out the vitreous from the posterior side as the first intervention that we are doing. We put in tricot. Once we have put in tricot, you can see this is the vitreous coming towards anteriorly. So we take out all the vitreous that we can, so that the distortion or the fluid hydration of the vitreous is reduced. So you can see it's a reasonably mobile nucleus that is there. So we have got a good capsulotomy despite this mobility problem, which would have caused a problem in manual disruption, manual capsulorhexis. We have put in an endocapsular ring. We have got it centered. And you can see the minimal amount of manipulation that is required for the nuclear disassembly because of the fact that we have pre-sectioned the nucleus because of the power of the femto. Now, once we have done this, you can see we will remove the epinucleus, which is there. The epinucleus, once it is removed under these circumstances, we are using a bimanual irrigation aspiration now to take out the cortex and the part of the epinucleus, which is there, as gently as possible. And you can see that I have got a reasonably centered capsulorhexis now, as the bag has moved towards one side because of the endocapsular ring that we have put. So this is the removal of the cortex, which has been done. Putting in viscoelastic, again, do not allow it to be decompressed by just taking out your fluid, because you do not want the whole back complex to come forward. And we are putting in a 3-piece lens, which will help us center it pretty well. Now, again, we go in with the cutter, and we will remove any vitreous that is available, which is there, which could be causing. So you can see there is some vitreous which is coming right here into the wound, which was there right in the beginning. You can see there, this is the stained part where we had put in the tricot. And we will now change the hands, in the sense that we will put in infusion from the pars plana, and you can see we'll just have the infusion, and we will use a cutter from this side. We have already applied a suture, and you can see that whatever excess vitreous is there, that will be taken out in this particular case. So you can see that we get a good outcome even in subluxated lenses. Only if the lens is so much fully, it's like it's dangling, then you will not be able to do any capsulotomy even with a femto, and you will have to use a posterior approach. But subluxations up to a reasonable extent are best managed with a femtolaser procedure, which is there. So friends, I have shown you a couple of difficult situations which femto has made easy. And I would say, as technology of the femto cataract is evolving, it is finding widespread use in complex cases. That is where the bar is raised. It is not just the normal cases, but in complex cases. In normal cases, there is repeatability, there is perfection, there is simplification that is happening. Obviously, there is a cost, and as the cost of the machine and cost of the LOI comes down, I am reasonably sure that what we thought about phaco in the early 90s would be the same that we will be talking about with femto in the next 5 years to come. So I think, friends, it's the time to take the leap of faith and switch over to the power of femto. There are enough patients who can afford this and who can get good outcomes with the femto procedure. Thank you very much for your kind attention.
Thank you, Professor Maipal sir, for this wonderful and informative talk on femtolaser-assisted cataract surgery. Now, may I request Professor Namrata Sharma, our panelist, to...
Dr. Ili, can I make a small comment? I am Lalit Verma here.
Yeah, yes, sure, sir.
Yeah. You see, we just heard Dr. Maipal delivering a talk on flax, the state-of-art technology, the glamorous surgery all over the globe. Very relevant. Prior to that, we had talk by Sandak Rohit. His thrust was primarily on manual small incision cataract surgery. Both seem to be contrasting, but believe me, both these gentlemen Both of them I know very, very closely. I just wanted to, add that both are pioneers in their own field, and both are committed, workers, work with a lot of passion, and both have made a mark for themselves. Rohit has, even made global mark. He was featured on Time magazine. I remember reading that article also. Couple of points I wanted to tell was, which a lot of people may not know, that both work with a lot of passion, and both are Padma Shri holders, and other thing is both are class fellows. Both I think did PG together, and so much they both have achieved. So I thought I'll share a couple of things which a lot of people in the audience and amongst the panelists also may not know about these two great gentlemen. Hats off to Rohit and hats off to Mahipal. No, Rohit.
Yeah.
So Rohit was my group leader. I still remember him, virtually taking rounds early morning. Rohit, I can't forget those days. Ward 3A, Rohit will come early morning and starting round before Dr. Tiwari or Dr. Garg comes, and he has been my mentor. So I still remember those days, Rohit.
Thank you very much, my
It was
dear.
great listening to you, Rohit. And
Yeah.
Mahipal also, we keep listening so often. So both
Sure.
class fellows, both PhD holders, both great people, both pioneers. Congratulations to both of them.
Thank you,
And
Including
Lalit.
you, Lalit.
and
Including you, Lalit. You too. You too.
Thank you, Dr. Malla. But it was a treat to hear both of them. You see the passion with my friend Rohit spoke. And equally important talk was of flags. So I actually congratulate Dr. Ben Limbu to bring both of them at the same platform. Thanks, Dr. Limbu, for all this.
Your idea too.
I'm sorry, Eli, for taking this 1 or 2 minutes because I thought I couldn't resist myself because I was part of the same system in RP Center with Rohit here and with Mahipal there, and both now have huge names in this subcontinent.
Yeah.
Great.
Our pleasure to hear you, Lalit.
Yeah. Thank you, sir.
You made your points. Good.
Over to Eli.
Thank you, sir. Now, may I request Professor Namrata Sharma as a panelist to speak?
So it's very hard to follow Dr. Mahipal sir and to, as a panelist, comment on his presentation. I have been his postgraduate student and I did my first IOL, in fact, as a PG. He gave me the first IOL to do. So it's been a long journey for me as well. And about his passion, I know how he works. The way, if I had forgotten in between, then I remembered again when he took over as AIOS president, and we've been working for last few months on it, and so that has rekindled again. But I think sir covered very well, and especially the complex situations in which femtosecond laser has made a lot of difference. Particularly the postage stamp sir technique that you showed. I don't think I have seen this, and I'm sure it'll soon be published soon, because that is something which is new, that it helps you to bridge the gaps or fill in the blanks where the femtolaser cuts, and the areas which are uncut can be very easily bridged, which if you do it with a forceps or if you do it with the scissors, then it doesn't happen that well. And of course, the last case was also a treat to watch, which was a subluxated cataract, and how the whole thing, was customized so that it shifted eccentrically to actually center on the subluxated lens. So I think both the cases were really very good, and femtosecond laser has made a lot of difference. And again, like Dr. Lalit Verma said, it was a treat to watch both Sir's presentation, which is always, and Dr. Sandak Ruit's presentation on the same platform. So if there are any other comments, I think we can take them. But uh, for us, it is always a learning whenever such kind of presentations are given. We pick up always something new.
3 cheers to both of them. Great talks.
1 minute. Lalit.
Yes, sir.
Yeah, I want to add one thing about, I'm meeting Sachdev for the first time, but what I want to say, the way All India Ophthalmic Society is running training program, I have been watching for the last few weeks, Chitra is there and yourself there, and wonderful postgraduate teaching under the leadership of Sachdev, as president of the AIOS.
That is
Congratulations.
true. That is
Isn't
true.
it? Congratulations.
Yes, that is true. Sir.
Beautiful.
Thank you.
Thank you, sir.
I think it's a team effort and everyone is doing their best. And I think AIOS is really come of age. And we are also giving a lot of emphasis to youngsters to come forward. And there are a lot of innovative talks that they are doing. And
Oh, yes.
everyone
Yeah,
from
very young people, dynamic young people, you are the president. Credit goes to you. Congratulations once again.
very much for your support and everybody else's support. And we look forward to doing well in the years in the able hands of people who are sitting here. And obviously, the previous people like Dr. Tiwari, Dr. Azad, lots of presidents who have been there earlier, who have and secretaries who have taken.
Anyway, it was a pleasure to have you in Sao. Thank you.
Look forward to continuing being with you. Thank you.
Thank you, everybody. Now we'll move on to the next talk on simplifying cataract surgery with Jepto and Lalit by Professor Sanjay Kumar Singh. Let me go through his short introduction. Professor Sanjay Kumar Singh, he's medical director of Biratnagar Eye Hospital. He's again another talented, visionary, and young, dynamic leader. Following qualification with MBBS from Institute of Medicine, and he had long-term fellowship in cornea and anti-segment from LVPI, and MSc in Community Eye Health from London School of Health and Tropical Medicine in 2005. He had Distinguished Service Award 2008 APAO, NNGS in 2017, and SAO Excellence Award 2018. He is founding medical director of Miti Eye Hospital and as well as Biratnagar Eye Hospital. He is program director of Eastern Regional Eye Care Program and currently is hospital director of Biratnagar Eye Hospital. He has been past president of Nepal Ophthalmic Society, and he has started phaco surgery on a regular basis in Nepal since the year 2000. And he has many presentations in and around the world with publications, and he's the first person to release video of phaco-emulsification, SICS, and pediatric cataract surgery in Nepal. Welcome, Professor Sanjay Singh, and you welcome to the webinar.
Okay, so am I audible now? Yes?
Yeah.
Okay, so I'll be sharing my slides. But
no, your slide is not visible yet.
No, it is not allowing me to share my slides. Yes, now it is. So good evening, everyone. And it was great to listen to very learned people from all part of the Southeast Asia region. So I'll be speaking my experiences about Jepto and MyLoop devices. I do not have any financial interest in any of these products. So as we all know that two important steps in phaco surgeries are capsulorhexis and lens nucleus fragmentation. And Jepto capsulotomy device, it helps us to perform the capsulotomy in a very simple and precise way. Similarly, MyLoop also allows us to do the lens nucleus fragmentation in a very simple and effective way. So there are three main challenges in the CCC, that is the round, and it has to be size is another issue, and it has to be centered around the visual axis. So the Jepto-capsulotomy system, it has the control console and the disposable handpiece along with the capsulotomy tip. If you look into the details of the capsulotomy tip, it has the soft clear suction cup. It has the nitinol capsulotomy ring that is round in shape, and the central clear area for the unobstructed view for the visual axis centration. And when it has the push rod, and when the push rod is dislodged, this nitinol capsulotomy ring is round in shape. And when we push the push rod, it elongates so that we can pass it through the smaller incision of about 2 millimeter to 2.2 millimeter incision. And once it is into the entry chamber, we can again pull back the push rod so that it again becomes the round in shape. And then the suction is applied so that it is firmly attached to the entry capsule. And when the power is applied to have the cutting effect, and when the power is applied, you can see this air bubble over there. And once the suction is released, we can have a very nice capsulotomy after this procedure. So the whole mechanism of this Jepto capsulotomy is that like the suction is applied and the capsule is pulled against the ring edges, multiple energy discharges, and that causes rapid phase change of the water molecules into gases. And this expansion of the water molecules into the gases, it causes the cleavage in the entry capsule, leading to the capsulotomy. And these are the different edges that is seen by the scanning electron microscopy. And this is the edges that is seen by the Jepto, this is by the manual CCC, and this is by the femto. And this is the capsulotomy video by the Jepto that have done it at Biratnagar Eye Hospital. So this is the case with the white hypermature cataract and with the raised intralenticular pressure. Usually, like it is very difficult to perform the capsulotomy or the capsular access in these kind of cases with the needle or with the forceps, because there is always a chance of having the Argentinian flag. But with the Jepto, we can do it very easily. You can see the gush of fluid that is coming out after this capsulotomy. So there is a small tag, and we can visualize that a very nice round central capsulotomy is performed. There are two publications that is mentioned by, one is by Dr. David Chang and another by Thompson. They have mentioned that it is a very safe and effective procedure. And in fact, like they have compared the precision pulse capsulotomy along with the CCC and femto, and then the capsule strength is much better than the CCC or femto. In my experiences with the first 100 Jepto cases that I did, in 93% of the cases, the capsulotomy was round and central. Capsulotomy edge was fairly strong, and I didn't have any problem like doing the phacoemulsification procedures. There was no serious complications noted, and minor complications were in the 7% of the cases in my initial 100 learning cases. So these were like the incomplete capsulotomies. Like here, I am performing the capsulotomy, and then after,
Your slides not moving.
Sanjay is not audible here. Well, not audible also.
Probably it's the net.
Net connection here. Meanwhile, Ili, can we have some comments from Dr. Harbansh Lal, because I called him because he has maximum experience of Zepto here.
Yeah, okay.
Harbansh,
So,
can you?
Sure, sir. So may I request Dr. Harbansh Lal to comment on Jepto capsulotomy, sir?
Unmute.
Oh, yeah.
Harbansh has to unmute.
He has to unmute.
like,
Hello.
is there any problem?
Yeah.
So can you hear me now?
Yes. Your slides, we are not audible, and your slide got stuck.
But here, like, it was moving very easily.
Hello.
Yes.
Yeah, Harbansh.
I think Dr. Sanjay is back. I think let him have his presentation finished.
Yeah, Sanjay can.
Yes, yes, sure.
Start sharing again.
Complete, yeah. It's working.
So now, am I visible now?
Yes.
Yes, carry on.
So in some cases, I had the incomplete edges, but despite having the incomplete edges, I could put the lens very easily in the bag. So this is the second device that I'm going to speak about. This is the MyLoop. It also has a nitinol ring, and it is the pen-like structure, and it has the pull and push button. When we push the button, the nitinol ring becomes large in size, and when we push the button, like pull the button, it becomes smaller in size. So this is the video. So can you see the video now?
Yes.
Yes, yes.
So this is the case with the white mature cataract, and here I am performing the capsulorhexis with the like the Utrata forceps. And because here the lens, like the cortex is very soft, so I'm inserting this MyLoop, and it goes very easy to the equator and then posterior to the lens nucleus. And with the second instrument in my hand, I am pushing the lens nucleus down so that it doesn't come out through the capsulotomy edges. So I have divided it into two halves, and then after rotation, I'm inserting this MyLoop. So it goes very easily surrounding the lens nucleus. And usually in my phaco surgeries, I divide the nucleus into 4 quadrants. And then the whole process is very easy. And if you look into the size of the these lens fragments, these are very nicely divided and and it really requires a little bit less phaco time. Another case like with the brown and mature cataract, usually I have done with the MyLoop like in all types of cases, like with the immature cataract, with the white mature cataract, and with the the hypermature cataract also. So in this case, I've combined both the capsulotomy and the MyLoop. So capsulotomy I have done for this capsulotomy, and MyLoop I have done for this lens nucleus fragmentation. So here after doing the hydrodissection, I am passing the this MyLoop. So it goes very easily to the equator, then posterior to the lens. And now here it is very nicely visible that I'm pushing the lens nucleus a little bit down so that it doesn't come out through the capsulotomy edges. So it has divided it into 2 halves. So though MyLoop can be used for like immature cataract and all types of cataract, but I found it more useful for the cases with the brown nucleus and with the black nucleus, because these cases are quite challenging for doing the phacoemulsification. And with the help of MyLoop, like I could divide the nucleus very easily, like within like 20 to 30 seconds. And then after this really decreased my phaco time like anything. And so because this is a very, very hard cataract, so and then there is hardly any cortex left in this case because everything was very hard. So after doing this irrigation and aspiration, I implanted the Acrisoft foldable intraocular lens in the bag. So to conclude, like in my experience, I found that the Jepto capsulotomy is a very simple and effective method to perform the capsulotomy. And it is more useful for the cases where there is the anterior-capsular fibrosis or with the anterior-capsular plaque or cases with high intralenticular pressure. And MyLoop is a very simple and effective method for doing the lens fragmentation, and it is more useful for the cases with the brown mature cataract or with the black mature cataract, where the cataract is very, very leathery. And with the combination of the Jepto capsulotomy and MyLoop, the difficult cataract cases can be simplified in a very effective way. So thank you very much for giving me this opportunity. And I'm sorry that in the initial period, like some of the slides you couldn't see.
Ultimately, we saw all these sides. Yeah.
Okay, thank you.
Thank you very much, Dr. Sanjay, for a very informative talk. Now, I would like to request Dr. Harbansh Lal for his opinion.
Sanjay has given an excellent presentation and very good quality videos and very well done surgery, sir, all of them. So far as Jepto is concerned, I think they need to improve the ergonomics because the neck part is very weak. So sometimes when you put it inside, the centration may not be very, very accurate. And it has to improve in this sense. Once in a while, I had few cases where the suction will not release, or the fluid comes with the jerk, which I mean, you don't need a hydrodissection to do, and it makes the things a little muddy. And we are pulling it out. I now push it in slightly and then pull it out because the capsular extension towards the incision is very common when you pull it out. Sometimes capsule may get entangled. So tags and slight eccentric. Even I had one case where the handpiece will not work, suction will not build up. So I feel they need to improve it little more to be used universally. And in a mature cataract, you forget to pull the push rod. You may have the Argentinian flag sign because as soon as it sucks, the capsule may get torn over there. Once you pull back the push rod, the neck part becomes very weak and it's very difficult to really move the head with that. So I think they need to improve a little bit of this. Otherwise, this is a very good technology. The capsulotomies are very, very strong. And now, whenever I get a mature cataract, white Morganian cataract, intermittent cataract, the patient has to go for Jepto because it gives me peace of mind and I am able to get a very good capsulotomy. So this, for mature cataract, there is no better technique than this. It does not take any extra time like femto, take to the patient to the another OT and then do it. I have not used the MyLoop technology, but it seems to be fantastic in your hand. And I'm sure that if I should try it out and see how it works in my hand. But overall, excellent presentation. And it's a Jepto is a must in every OT because it's a not very heavy investment. I mean, as compared to the Femto, just 9-10 lakhs rupees of the equipment and 13,000 rupees for the disposable handpiece. So it's a very handy, very good and good technology. If they can improve it a little bit and have a different sizes of rexes and little better suction mechanism, release mechanism, maybe they can make some hole on the uh, silicon sleeve for the bimanual centration of the device because you can go from the side port and center it better so that it can be universally done. So but as of now, I really, if the simple cataract is there, I rely upon my manual CCC. If I got to do a multifocal IUL or trifocal IUL, I rely upon my manual CCC more if it is a simple cataract than on a Jepto CCC because once in a while, nearly 3% of the cases I had tears and tags. So I feel they need to really improve the technology a little bit more than what it is at present. Thank you very much for giving me this opportunity.
Thank you very much, sir. And thank you, Professor Sanjay Kumar Singh. Now we'll move on to the next presentation, which is the last one now. Overcoming the challenges of toric IOL implant by Professor M. Nazrul Islam. Before that, I would like to go through short introduction. Yeah. Share. Professor Nazrul Islam, he is Professor and Chairman, Glaucoma Faculty of Bangladesh Eye Hospital Institute, Dhaka, Bangladesh. And he has MBBS and MCPS and Diploma in Ophthalmology with FCPS in 1995. He has gold medal awards in different parts of abroad and home. He has publications, more than 60 in 60 scientific publications, and he's been editor of Journal of Ophthalmological Society of Bangladesh, Bangladesh Academy of Ophthalmology. Present is the chief editor of Journal of Bangladesh Glaucoma Society. He has 5 books on eye diagnosis and treatment in Bangladesh. He is currently president of Bangladesh Society of Cataract and Refractive Surgeons and Bangladesh Eye Care Society. He's past president of Bangladesh Glaucoma Society and chairman of Board of Management, of Jishore Community Eye Hospital, and he is executive board member of APGS and Asian Angle-Closed Glaucoma Club. Welcome, Professor Nazrul Islam, for your talk on overcoming the challenges of toric ion implant. Yes, sir. Professor Nazrul.
So am I visible?
Yes.
Okay. Thank you very much,
Yes,
Dr. Eli, for your kind introduction. Good evening, everyone. I'd like to thank the SAARC Academy of Ophthalmology, especially President Malla sir, Secretary General Dr. Rajvardhan Azad sir, and here is my teacher, APAO President-elect Professor Hossain, and all distinguished ophthalmologists in the SAARC region, and all my delegates. Again, good evening, everyone. I'd like to thank also Dr. Ben Limbu for inviting me in this prestigious webinar. So my topic is overcoming the challenges of toric IOL implant. And you know that my topic actually is for those who are now trying to learn or try to do the toric IOL implant, not for those who are already doing it. So when they want to learn the toric IOL implant, they have some challenges like the new procedure, marking preoperatively, perioperative marking, doing the surgery, prevention of the postoperative rotation. So these are the challenges we face during the toric IOL implant. So as Dr. Rajvardhan Azad mentioned, that we're learning every day. So we learn cataract surgery from ICC, ECC, SICS, phaco, femtolaser, now doing the toric IOL refractive surgery for our patient. If we look to the different studies, one study by Dr. Hoffman done in 24,000 eyes, we find 74% of eyes have the astigmatism preoperatively. So we need to address some kind of it. And in another study by David et al., in recent study 2018 published in Clinical Ophthalmology shows that 25% of our patient actually needs the toric IOL implant. Dr. Maipal Sachdev rightly mentioned that if you use the flax, you can do LAI, laser arcuate incision, to correct the toricity at least less than 1 diopter. But when it is more than 1, you need to do the toric IOL implant. So friends, you see here, when you want to give a glass, a spectacle to one of my patient, what we do? We give this cylinder power for a patient, not only the spherical power. So when you want to do the cataract surgery, then if you do not put this cylinder power, how my patient will see if he has cylinder power? So there is a question. So definitely, when we want to define any kind of cylinder power, we have to counsel the patient. And this is the pathway of counseling is at my institute. Whenever a patient come to us, go for the auto refraction. If we find some astigmatic change, K1, K2 difference, we hint the patient, okay, Mr. X, you have some power that is different than the normal, and you may need a kind of different lens, the toric IOL. Patient go to biometry. The technician also says you have some different kind of power. Go to the counselor, she or he also says you may need a different kind of power, a toric IOL. When the patient come to me, after dilatation, I examine the patient, I then explain to the patient. I explain like this, you have a toric power, you have a cylinder power. If you do not correct it, you will see a little hazy after surgery. Say if you have 1 diopter cylinder power, if you do not use it in the toric IOL, you will see a little bit hazy. If you have 1.5 diopter, if you do not correct it, if you also have taken this from Ophthalmology University, that actually helps. The patient understands better. The counseling becomes good. So my request to the doctors who want to do this toric IOL implant, take the easy cases, take the regular stigmatism cases, not the regular one, and take at least one diopter, more than 1.5 diopter cases. So it becomes good for the patient outcome. First of all, many people think that it needs a lot of expensive instruments. I say it's not, because with these simple instruments like this, simply a toric marker and excess marker, you can do your toric surgery. It's not very difficult. So I'll show you a very easy way of reference marking. You can do your freehand marking. Patient is to look straight ahead, and it should go to the, like this, the corneal reflex, straight in the middle of the cornea. So you can have a good reference marking, horizontal, like 0 and 180 degree. So it's very easy, anybody can do it. And recently the app is available, the Toric app, developed by Dr. Graham Barrett, the Toric Patwardhan, developed by Dr. Saurabh D. Patwardhan. It is really helpful. You can use these apps so that it shows you that how much you are in the hand, free hand, you are developed from there. Maybe 1 degree or 2 degree or 3 degree deviated from the original axis. So it is possible to correct by the apps. More important, in my practice, I use the slit lamp for the reference marking because it is easily available. Everybody has the slit lamp. With the slit lamp dram, you can make the horizontal, that is the 180 degree and 0 degree. And simply in the slit lamp beam, you can use a 26G needle, give 2 or 3 dots in the peripheral cornea, and give a scratch marking. And after that, you can also mark with a sterile pen, so that even if your pen marking fades away, smashed away, you can have your dot, you can have your needle dot during the surgery. So actually it helps. We should also learn the biometry. We should not give only to the technicians. We should also supervise how to do the biometry, how to calculate the IOL. Simply you can put the figures here and calculate. You have Barrett toric calculator, Alcon toric calculator. All the lens company has their own toric calculator in the online. It is free. So of course we should learn this calculating the IOL. Definitely you can use more kind of reference marker like bubble marker, pendulum marker, Akahosis, electronic marker. Definitely you can do. Even if we have the facility, you can use the very own image guided system, Callisto Eye. So definitely you can use, but it's not always essential. Very simply, you can use this marker here, the axis marker. 20 degree is the axis here. So put the reference marker, you put it here, and you put the 20 degree axis marker here. So you make the marker and you can start your surgery. So in this surgery, few things is very important. One is after the marker here, one thing I'm showing here, this is wrong for me that I didn't dry the eye. So what happened? There is a smudging of the ink. So in that cases, you can use again the 26G needle to make the peripheral corneal marking by dot. And important part is the incision. It should have a good incision, 1.5 millimeter square incision. It should have a very central, round 5.5 to 5.5 millimeter central capsular rhexis. Because the toric IOL, you need a good rhexis, otherwise that might have rotation post-operative. This is very important. Dr. Sharif Hashmani also mentioned that for a good surgery, for a toric IOL, for the multifocal IOL, we need a central round rhexis. Definitely is important. Dr. Maipal Shazda showed that if you use the flax, definitely you can have a very round and central capsular rhexis. So after doing the phacoidal inspection, you put your IOL at least 15 to 20 degree off axis, that is away from your desired axis. Then clean your antechamber, remove the vasculastics very nicely. Many surgeons use the hydroimplantation. It is really good, but in my practice, I use the OBD, the cohesive viscoelastic I use here. And before the final alignment, you must remove all the cohesive viscoelastics from the antechamber, from above the IOL, and also from below the IOL. We usually give at least 1 minute time to remove all OBD, because it is the problem that if a little bit OBD remains, there is a possibility of postoperative IOL rotation, which can actually lose the toricity of the intraocular lens. So you see after the final alignment, it is done. Sometimes we see that the axis placement becomes overshoot. It is on the alignment, it goes away. What to do? Then in that case, it is better not to go counterclockwise, rather go to clockwise again and again. And at the end, you can find again the 15 to 20 degree off to the axis and very carefully go to the alignment. And before that, you can of course do the corneal hydration. Yes, there is a chance, there is a challenge that IOL can rotate after surgery. And if it rotates, really it is 1 to 3 degree, it is forgiving. But more than 3-4 degree, sometimes the patient can accept, sometimes the patient cannot accept. If it is more than 10 degree, definitely you have to rotate again to the real axis. But fortunately, this re-rotation is very, very minimum. The post-operative rotation is very, very minimum. If you have some procedure like during the surgery and after the surgery, if you maintain like this, patient should not walk from the OT. Patient should go by the same table if possible, or at least by wheelchair, then go to the operating, the cabin or to the ward. Patient should lie down for at least 1 hour, because it has been seen in different studies that only after 1 hour, if you can patient lie down, there is possibility of rotation is very, very less. And after 1 year, we must examine the patient, is there any rotation or not? If not, is fine. And again, after 1 week and after 2 weeks, we should examine after dilatation. Is the rotation is more than 10 degree, if the patient between is less, definitely you have to re-rotate it again within 2 weeks of the surgery. Fortunately, the re-rotation and repositioning is very less. If we look to the study by Dr. Haripriya in Aurobindo Eye Hospital, they had only 1.3% repositioning of the IOL in 1 year. And another study published in India's Ophthalmology by Dr. Titial and his group also found 0.65 to 3% cases had needed the realignment after the surgery. Lastly, yes, for the toric IOL, if you have the facility of good instrument like IOL Master 700, the corneal topography, the Varian image guided system, Callisto Eye, definitely your surgical outcome will be better. And recently, most of the doctors doing the group practice. So definitely in the group practice, these machines are available in most of the institute. You can take the advantage of those machines and have very better outcome toric IOL implant. In my institute, we have both the facility of Varian and also the Callisto Eye. So my assistant doctor can help us by taking the registration of the patient's eye here out in the OPD. And in the operating room, we can see our patient's optimum size of the axis, the surgical axis alignment. We can see even the incision site, everything we can see. And at the end, we can align the IOL according to the patient's IOL without any marking of the ink. Simply digitally, you can do it. Definitely, but it is not the necessity. It is not that without this, you cannot do the toric IOL implant. This is not the message that you need these things, but definitely if you have this facility, it will improve your surgical outcome. And lastly, toric IOL is expensive. This is another challenge. Definitely, it is more expensive than the monofocal IOL. But in our developing country, we find in the market, there are some cheaper IOL also. So we can use that IOL also for our patient who cannot afford the costly IOL. And one thing is, this is a lifetime investment. So definitely, if you use one toric IOL, the patient may not need the glasses for his or her distant vision postoperatively for his lifetime. So actually, it's a lifetime achievement, a lifetime investment, and it is actually, that is the thing, the lifetime achievement, that he does not need the glasses for distant vision if we use the monofocal. But even the patient uses the multifocal toric, he may not need any glasses in his lifetime, definitely. So in summary, I request our colleagues who wants to use the toric IOL implant, you need determination. You have to take a determination that I will do it. You need to do good counseling to our patient. Practice marking of the IOL even to your monofocal normal routine cases. Do 5 or 10 cases, definitely you will find that you are more confident to the toric IOL implant. And I hope with this, you will overcome all the challenges to do the toric IOL implant even in the developing country in the SAARC region. Thank you very much, sir.
Thank you, Professor Azad, for excellent talk on toric IOL implant challenges and its ways to overcome. Now, may I request Dr. Irfan Jiva, our panelist, to give your views on this. Thank you.
Dr. Nazrul Islam, greetings from Pakistan.
Thank you. Thank you.
That was an absolutely wonderful presentation, and full marks to Dr. Limbu for having presentations where we're talking about countries where doing cataract surgery is a challenge to really cutting edge technology from flax to toric IOLs. Just going to comment on a few things of this really wonderful presentation, which I'm sure is a source of inspiration for a lot of people who want to start. So in my practice, I only use Verion for all my patients, and my cutoff level is 0.7. And there's a Scandinavian study that shows that toric IOL is more cost effective because of the reasons that you very correctly and rightly described. So any patient of mine who has 0.7 astigmatism or more gets a toric, or at least gets counsel for toric IOL. Another very interesting thing was lying flat for an hour. So we did a bit of local audit. And the result of that is now I do not make any of my patient lie flat for even more than a minute. They sit, they walk out, and they're absolutely fine. And when we audited my last 200 cases, only 3 IOLs rotated, of which only 1 required repositioning. So we are fairly confident when we say that it's okay, just get up and walk. I don't want you to lie down flat for an hour. But again, these are different preferences, and by sharing this kind of information, we continue to learn more. I quite liked your the flow of your clinic, where as soon as the technician observes a small change, they at least start to counsel the patient. So by the time the patient comes to you, and Dr. Nazrul Islam, that's something I've learned from you today, and I'm going to implement it.
Thank you. Thank you.
Really helps with patient counseling when they've already been primed for it, because there is a problem, and then it's up to them whether they want to go for a toric IOL or not. Overall, I believe that one of the best advances in cataract surgery is the toric IOLs, and it is so heartening to see wonderful work being done in Bangladesh, which is country of my parents. I've been there a few times. And thank you very much for sharing your experience with us.
Thank you, Dr. Irfan. Thank you.
Really, can I make a comment? Hello, can you hear me?
Yes, yes, sir.
Yeah, I'm Dr. Harbansh. Can I make a comment?
Of course, sir.
So the very important thing is that do not use methyl cellulose for putting the lens inside. Either use hyaluronic acid or use the hydroimplantation. I never use methyl cellulose because methyl cellulose can never be completely removed from the capsular bag. So irrespective of your effort, you cannot remove it. It will remain there. And after this, when you are withdrawing, I do hydroimplantation. While removing my cannula, I inject the air from the side port, which will compress the IOL down. And do not overinflate the bag. If the IOP is high, the capsular bag gets inflated and the lens will rotate. So that means no viscoelastic in the bag, air pressure from the top, and eye on the softer side. I was probably first person to use the star toric IOL in this part of the world, which was silicon plate haptic. And when this was a thesis topic, I used imported 40 lenses. I analyzed the 2 lenses we rotated at that time maybe 25 years back, I use the methylcellulose in those cases. So my take-home message is do not use methylcellulose, either use hyaluronic acid or use the hydroimplantation. And the toric IOLs in India at least are available at the less than 6,000 rupees, the local manufacturers, which is the cost of the monofocal IOL of the imported variety, which are very good quality and they are actually come off the ace. So anybody who needs toric can go for the monofocal price with the toric IOL also. And in the preoperative evaluation, if the readings are varying in the, at least there should be two machines which are giving the same reading. And dry eye is one thing which you need to really take care of. Once in a while I had to explant the IOL. It was because of the dry eye, the keratometry was not correct. So take care of the dry eye. If readings are not good, treat the patient with the fluorometholone and for lubricant eye drops for a week or 2 weeks and then take the readings. You'll be better off. Thank
Can
you
I
very
ask a
much.
question to Dr. Lal and Dr. Nazrul Islam together? So there are various methodologies of accessing information regarding the axis and the amount of astigmatism. So we have the biometry, we have the autoref, we have the pentacam, and various other methodology. Which ones are your preferred methodology for committing to that axis and astigmatism?
My one, if I say my one is corneal topography, when we do biometry in IOL master, definitely that also gives you a good amount of astigmatism difference. But I take mostly on the topography present, because topography gives me better result for the amount of astigmatism in my practice. And Dr. Lal can add, of course.
You need to understand when you take a reading with the pentacam, so there is an anterior surface it gives, and then there is a lens star or IOL master which gives the anterior surface. So you need to keep in mind that you are comparing the anterior surface with the anterior surface. Do not compare the total corneal refractive power with the anterior surface, then you will be confused. So compare the two machines, whether they are in agreement or not, with the anterior surface readings. And also the optical zone, because pentacam will give reading 1 millimeter, 2 millimeter, 3 millimeter, while the IOL master and lens star will give 2.1, 2.3 millimeter. So you need to compare that zone. And then I take the total corneal power of the pentacam for the correcting of the astigmatism. But to find out whether the readings are reliable or not, you take that zone. And again, whatever the Western literature, they take 4.5 millimeter. But for my patients, I take usually because this subcontinent, the pupil size is not more than 3 millimeter of these elderly patients. So I'll prefer to take a reading which is between 2 to 3 millimeter zone than taking the 4.5 millimeter, which the Westerner takes, because their pupil is a light color. So they may take little larger size. But I personally feel that it is the 3 millimeter zone which gives you better idea. So total corneal power of the pentacam is probably more reliable. But if there's a lot of variation, if there's not, then I definitely give the patient steroids and lubricant and recheck after 1 week or 2 weeks if he's going for a premium IOL.
Has any one of you tried the Verion biometry? Because we found in our audit that it was always completely off. And what we found was the IOL biometry was almost comparable to the total corneal power of pentacam.
I think I would
use Verion.
completely agree with you on this, that Verion is completely off, and IOL master that you do is quite reliable that way.
No, the only difference is because IOL master and Verion, they take anterior surface. So if it is an oblique astigmatism, if it is a higher astigmatism, if it is a very low astigmatism, that means when you are correcting 0.7 you took as a cutoff, then you definitely need to have a pentacam reading. Without doing a posterior corneal surface, if you do 0.7, it may be 1.5, it may be 0 actually. So if you are doing a very high, because the posterior corneal surface influences the higher astigmatism more. And if it is a vertical astigmatism, and if it is an oblique astigmatism, if it is an oblique axis, if it is a 4 diopter, the posterior corneal actually may be 1.5 diopter. So many times Verion when you are doing are the only anterior surface doing, it is good if it is a moderate astigmatism, if it is a horizontal axis. But if it is very low, very high, oblique, you need to have a pentacam posterior corneal surface evaluated.
Dr. Lal, I'm going to ask you, take this opportunity and ask you this very important question, and to our lovely panel over here who are also very experienced. So we agree that we all tend to use pentacam quite a lot. For the pentacam, when the axes are slightly irregular, so the astigmatism is slightly irregular, at what level do you say, okay, this is an irregular astigmatism and I'm not going to pursue this further? And just to let you know, on top of that, that we found that when the axis was more than 21 degrees off its straight line, we were just not happy with our outcomes. Would anyone of you like to share your wise experience with us, please?
Whenever the cornea is irregular, whether it is because of a keratoconus or corneal opacity, then the astigmatism is to be corrected on the basis of the refractive power of the spectacle. So then do not go by the keratometric reading, then go by the refractive power. So then, because what is the patient acceptance? If suppose you are correcting a keratoconus or post-keratoplasty or corneal opacity, where the keratometric readings are haywire, then I see the acceptance post-RK patient. So then I see a coloboma patient. So all those patients where your readings are not correct, then go by the refraction. So if you find the refraction in that particular axis patient improves, go by the refractive error of the patient. Unless the corneal readings are very smooth, only then you go by the keratometric reading. If the corneal readings are, after treating the dry eye, if the corneal readings are haywire, I rather prefer to go by the acceptance of the patient.
I guess what Dr. Irfan was meaning was more than 20 degrees off with the rule or against the rule. That's what you meant, right?
Yes.
Yeah. So actually, it is well known that toric IOLs work best for with the rule or against the rule, and if it's oblique, then the result may not be that good as proper with the rule and against the rule. So that's why a little bit off with the rule or against the rule. If it's oblique, then the results may not be as good as some.
So, Professor Sinha, at what angle is your cutoff? What's your threshold, Professor Sinha?
I guess it's 20 degrees only from the vertical or horizontal.
No, that means if the patient has got 35-degree angle, you will not put the toric IOL. No, what does mean cutoff?
No. See, actually, it's truly speaking, we don't consider it as a cutoff, but the results may not be as good. It's a known fact that for with the rule and for proper against the rule, the results are better than for oblique astigmatism.
Why? What is the reason for that?
It is observation noted in the studies, and but then no. But the people have not said that they will not put a toric IOL if it's an oblique astigmatism. But studies have shown that the results in oblique astigmatism is not as good as a vertical or horizontal. That is
If I analyze, only reason may be either your incisions are not correct. I mean, this is more corneal incisions, so the axis may change after you've done a keratometry before surgery. Your incision gives a little more astigmatism, so now actual axis is entirely different than what it was originally. Or the posterior cornea has not been estimated, or the lens are rotated afterwards. So the lens rotation can 100% be prevented by injecting the air. And if you want, like in a DSEC, put the air per full chamber per a minute or two, lens will get stuck there. And if your incision is little limbal, there should be no problem of inducing the astigmatism. And if you analyze the posterior corneal astigmatism beforehand, I do not see any reason why the oblique axis should not give a good result. I have got no problem with any of my patients.
No. It's not a question of
Rajesh, who is moderating?
Ben.
So hand over to Ben then.
I think let's close it over.
Hand over to somebody now. We can go on like this,
This session now this ends the sessions for the speakers, and now the forum is open for panel discussions, which already been happening now. So I'll hand over to.
Well said.
Short because we are running out of time. So Dr. Ben, to continue as a panel discussion, because they're having a good panel discussions anyway.
That's great.
Thank you,
Half
Dr.
done.
Thank you very much. Well, I think the most of the panel discussion has been already done, but I'll take few questions from the audience.
Okay.
One of the audience has asked, what is the best viscoelastic solution if you have a hypermature cataract? So the question, Namrata, ma'am, can you answer for this question?
So if you have
Because I use whatever I have. I normally use the methyl cellulose for even for hypermature cataract, because that's only thing that I have with me. So
if you have a hypermature cataract and you're doing, say, SICS, probably it will not make too much of a difference. But if you're doing a phacoemulsification and you are going to use an hypermature cataract is hard, then you would probably need a dispersive kind of viscoelastic like Viscoat with no financial interests. And if it is not hard, it is soft, then you can do with any kind of viscoelastic agent. But I would prefer Viscoat for all cases which are hard or where you think you are going to use more phacoenergy.
thank you, madam. So another question that I got from the audience is, this is for Professor Dr. Sanjay Singh, sir. So is the MyLoop device reusable, or it's a one-time use? And is it cost effective if it is one-time use? That's what the question is. So you need to unmute, sir, I think.
Oh, yes, sir.
Yeah.
Okay. If you use it for, if you want to use it for one surgery, then definitely it is not cost effective. But in our setup, like I've been using it by doing it with the ETO sterilization. And with one, like I can use it for the 20 cases. So I think in that scenario, it is quite cost effective.
So high volume places will be definitely benefited with the MyLoop, but the center where there's low volume.
Yes, but you could get the ETO sterilization facility as well.
Yes.
Of course, the company recommendation is for one case.
Yeah. Thank you. So I have another situation for Professor Harbansh Lal sir. So if we do a cataract in one patient where patient is emmetropic in one eye, and somehow with the biometric mistake or biometric error surprise we see in the other eye, maybe like -3 diopter in the other eye. So how do you proceed, sir, in this situation? Sir, I think you need to unmute, sir.
I think it depends whether you have got your own setup PRK or LASIK facilities available or not. Okay. So if that facility is not available, and IOL exchange can easily be performed without any problem. So I got my very simple technique of IOL explant. So IOL can be explanted even 10 years after surgery. So, and every surgeon who is putting the lens head must know how to explant the IOL. Reason is that when you put on a multifocal IOL, if patient is unhappy, you will be on defensive. Every time he comes, and once you tell him that come tomorrow, and it is included in my package that if I put on a multifocal IOL, any refractive correction is free of cost. IOL exchange with the monofocal is free of cost. So we tell them anytime you are unhappy, I'll cut it, remove it, and place another IOL in. So if patient is unhappy, we need to make patient happy, and any company will accept the broken IOL back free of cost. So it takes hardly any time. It takes 2 minutes to remove the IOL from the eye. So take the patient in, cut the lens. If you want, I can explain in a minute or two if you want me to explain how to expand the IOL, and then put the another IOL inside. If it is within a month, you can put a single piece IOL into the bag itself. But if it is little older, you got to keep the inventory of the 3-piece IOL with you. But the IOL can be easily removed without any problem, So if nothing else, you must explant, give it back to the company, they will refund you.
Thank you, sir. Thank you. So I think your message is very clear that if you have a femtosecond laser, go for laser, ablate the cornea, and revive the power or restore the emmetropia in the patient. Otherwise, just go and explant the lens and company will take back that lens, broken lens. That's excellent. I think so. That's a great idea, and I think that should.
But I tell all my residents also to explain before they go into the practice. Don't explain the lens the way you have problem. Next day you go into the OT, cut a lens and remove it so that you know how to remove it. So don't do it when you are worried, you are tense. So why not to cut an implant next day and do it and send it back to the company? Broken loops, send back and get it replaced so that you know you have learned it beforehand. So don't wait for the complication to happen. Train yourself just now. Next OT.
Thank you, sir. I think we have answered most of the questions from the audience. Is there anything any of the speaker want to bring into account that and which needs to be addressed? Otherwise, we'll move forward with our regular program.
Do that.
Yes.
Yeah,
Thank you, sir.
Thank you, everyone. It has been very excellent from everyone. So now we are nearly approaching at the end, and I would like to request Professor Aba Hossain, President-elect APA and past President of SAARC Ophthalmology, and role model for every ophthalmologist around the globe. Welcome, ma'am, for the closing remark.
Thank you so much, Lydia. It is really an excellent and amazing session. It was supposed to be end at 3 hours, but now it has passed already 3.5 hours, more than that. So it will take some more times. I would like to thank the Nepal Ophthalmological Society, where the SAARC Academy Ophthalmology member are there, and they are the local organizer. They are the host actually. So thank you so much, Ben Limbu, Dr. Eli Pradhan, mainly, and Honorable President Professor O.K. Malla, and
thank you.
SAARC. Oh, you are still here. Thank you. Thank you so much.
Yeah. Thank you very much, Ava.
No, sure. Thank you.
I have to be here.
Okay. Professor Rajvardhan Azad, the dynamic leader of SAARC Academy of Ophthalmology. I would like to thank Professor O.K. Malla and Professor Rajvardhan Azad, as because it is their desire that we should continue the this way webinar in the every SAARC country, from every SAARC country, and already as noted in that way. So this time Nepal has organized in so nice way that cataract and what next. So the panelists, the learned panelists, Professor Gominda Padel, Professor Namrata Sharma, Dr. Harbansh, Dr. Irfan Jeba, Professor Lalit Verma, they have already given their comments and their advice. And already the last speaker, after finishing, I'm just very interesting watching how Dr. Irfan, Dr. Harbansh, and also Rajesh is also entering in that debate. So it is very nice session. I'd like to congratulate all the speakers, as because they have so nicely and elaborately presented their presentation. I individually like to thank Professor Sharif Hashmani. He was the first speaker and spoke on multimodal imaging in modern cataract surgery. See how happened. The visual acuity was 6/6, and it is a very desirable vision. But after that, patients are not happy. Why not happy? There are some problem. So to overcome that problem, how you will deal? In that case, he has nicely, elaborately presented, and Professor Namrata Sharma, she was the panelist in that session, in that speaker's presentation.
Your thing has frozen.
And here, Ili, I think
Is
that issue
is Ben there still?
There's some
Yes,
Ben there?
I think
Ben,
Madam,
what's happening?
network connection problem with the Madam area, I think.
That's so. Mhm.
I think Dr. Malla can conclude, give the remarks.
Shall we?
Yeah.
No. Yeah, I think it's already past 7 o'clock here in Nepal. Ben, what do you say? Eli?
Yes.
Yes, sir.
So what do you say, Eli? Is it all right?
Yes,
I don't know.
Yeah, yeah.
Take
Shall I
the,
call her and find out?
Yeah.
take her permission. Is she would like to continue or what?
I'm calling her now.
I think Madam connection is lost now.
Mhm.
So time to say goodbye.
Thanks. That's what I want to say. Anyway, from my side, if she comes back, she's okay. Rajesh is okay. I think.
Yeah, actually, but Dr. Eli is contacting her. If she's contactable and if she is joining, then it will be wonderful. Otherwise, we do duty, and that is a word of thanks. Which will be good.
I think because
is she joining, Dr. Eli?
Speak to her.
No, I don't. She hasn't picked up the phone.
I think she must
Okay.
be keen to join, but because of some
Yeah. So, sir, whatever you say, Malla sir, we will.
No, whatever. Yeah, because anyway, I hope she won't mind it. But then I don't want to go into detail. But more than I expected, the webinar has gone wonderfully well. I learned quite so many things, and the credit goes especially to you people. We are in the organizing team, all right, but the people who have really worked hard, if I have to name them. Ben is the one, I think he has put so much hard work to bring
ma'am has joined
webinar to this shape now. And she coming.
I think ma'am is back. Ma'am is
coming,
back.
Ellie?
Yeah.
Yeah, I think she's back. Yes.
Yeah.
Okay, let us complete.
Sorry, extremely sorry. I was
No,
out.
it's all right. Well, welcome
I was
back.
out.
We were waiting for you, ma'am.
Yeah, okay. Thank you so much, Eli. Next speaker was Dr. Sam Snowman, as he left, but he has an excellent topics because he has shown so many hyper-mature cataract, that is phaco in white soft cataract, phaco in white hard cataract, traumatic cataract, and all. So thank you so much, Dr. Noman. And in that case, Dr. Govinda Patil also explained it very nicely. And hypermature cataract, as hypermature cataract is in this pandemic situation, it will be increased, as we know that. So this is very important thing that we will have to face lot of hypermature cataract in near future due to this pandemic situation. So thank you, Noman, for your excellent presentation. Next speaker was Dr. Shamali Jafar. Excellent presentation from Maldives. I must say, as because she has said that the female are very much happy with the myopic error correction. It is very important thing, as because as myopic, they can see the near also, and they can see with the lens, they can see the distance. So it is very important. But the most important thing she has mentioned that the outcome is much more important. Whatever method, whatever thing you are doing, the outcome is the most important thing. Everybody will accept. And thank you so much, Dr. Shamali, for your excellent presentation. Next is the our invited special guest, that is oration lecture, Professor Sanduk Ruid. I must congratulate and thanks, my heartiest congratulations and thanks to Professor Sanduk Ruid, as because he has shown the cataract blindness, our perspective. All these are countries, he has shows the blindness pattern. And also Bangladesh, though Bangladesh, I think Bangladesh blindness is not 62%, it is much more, but still, I think he has shown it so nicely. And lastly, I will not go in details as because time is very short and everybody is tiring. Already I am seeing that something is happening in the photograph. So he has showed that without delivery the nucleus, already implantation of the lens. This is very nice thing in case of the hypermature cataract. So thank you so much. Heartfelt thanks to again Professor Sanduk, as because already Professor Lalit Verma has said something about the Professor Sanduk and Professor Mahipal Shazdev, as because both are individually pioneer of their own setup. One said about the manual small incision cataract surgery, and other said the flex. So it is very important where we were. And Professor Rajvardhan Azad has already started from the couching to the flex. So where we were, where we are now, and where we will be in future. So these are all very important thing. And Professor Sanduk has already said in the community level, challenges in service delivery in the community level so nicely. So thank you so much, Professor Sanduk. Now the next session is the symposium, and Professor Mahipal Shazdev have already presented it, flags in challenging situation. That is, this flags is only main important theme is the in challenging situation, not in the clean cut cataract, immature cataract, not there, but all the complex cases and all the challenging cases. And Professor Mahipal is really the dynamic leader of AIOS. After taking the charges, he has started his work along with the whole team, and I must say, I must congratulate the Honorary General Secretary, Professor Namrata Sharma, who is a very dynamic leader, and she is doing so much in doing all the training, all the, I am so surprising that it is very much make me happy that they are searching, Dr. Partho Bishwas and the scientific other team, they are searching the young talent who will be in future the main surgeon, the main leader. So they are searching that east, west, northern zone, central zone, everywhere. So I would like to congratulate Professor Mahipal, Professor Namrata Sharma, along with entire organizing team for your excellent work. And this is a lesson for us also, so that we will also follow you accordingly. As because learning, there is no limitation, and learning can, teaching and learning, these are the part in any age, in any way we can learn it. So this is a learning thing. Thank you, Namrata. Thank you so much. Next speaker was Professor Sanjoy Singh. He's from Nepal, and he presented simplifying the cataract surgery using the Jepto and Milo. It is an excellent presentation, I must say, as because I have seen this the first time, and the way with the Jepto, he has so nicely capsulorhexis has done, that is absolutely round and central in position. So it was an excellent way. And also with the Milo, the fragmentation of the nucleus, and then phaco is done. So this is very good presentation. Thank you, Sanjoy. Thank you so much for your excellent. And Dr. Harbansh Lal also comment in this presentation. And last but not the least, my student, my favorite student, he is Professor Nozrul Islam, and he has presented overcoming the challenges of toric IOL implant. Yes, explained in so nice way, and that is the main thing. How many of the panelists has participated in this presentation? So this is a very excellent one. Thank you, Nazrul Islam. Thank you so much. And everybody is, I don't know how many of you are present, but still, I think everybody is present. My heartfelt thanks to
Thank you,
all of
madam.
you.
Thank you. We are here.
And,
Thank you,
oh,
madam.
Nazrul is here. I understand Nazrul is here.
Thank you.
Excellent presentation, Nazrul, as because everybody joined in your presentation. So that was my privilege for me to say these few words about you, and you will do well in near future. So thank you so much, all the panelists. Professor Malla, sir, thank you so much. You are still here, and it is our inspiration that you are still here. And with these few words, I would like to say I'm the first president of SAARC Academy of Ophthalmology. According to that protocol, I'm saying all this, and SAARC will go on forward under the dynamic leadership of our Professor Malla and Professor Rajvardhan Azad. Professor Rajvardhan Azad, as a Secretary General, has done so many things, and it is because of him that SAARC Academy is still active. Professor Namrata Sharma was the treasurer. She knows how she worked with Professor Rajvardhan Azad closely, and I was the president at that time. So during from 2009 to 2014, 3.5 years almost, later part of the, no, from later part of 10 to 14. So I love SAARC Academy of Ophthalmology very much, and I love all of you. So please carry on and go forward with a hope that SAARC will occupy the entire globe, and we will fight for prevention of blindness. And that is our aim, and that is the aim of the Asia Pacific Academy of Ophthalmology, prevention of blindness. Thank you so much. Thank you.
Thank you.
Thank you, ma'am. It's because of your blessings and blessings of Malla sir and Azad sir that SAO definitely is going to be very effective in this region. In the end,
Rajesh,
sir.
Rajesh,
Yes,
Rajesh,
sir.
can we conclude it now?
Yeah, that's what I'm telling. That in the end, Dr. Ben has to do the duty of giving the word of thanks. So I'll request him to do that. Before that, on behalf of all of us, a big thanks to Dr. Ben for organizing it, and I would also thank Dr. Ellie for moderating it very well. Dr.
No,
Ben.
Rajesh,
Ellie and Rajesh for moderating. Thank you.
Rajesh.
Sir.
Rajesh, can you hear me?
Yes, sir. I can hear you.
Yes.
Rajesh, no, before we give the floor to Ben, that will be the last one.
Yes, sir.
Can I say a few words? Not too many, right?
Sir.
Anyway, I can't. Anyway, no.
Yes, sir.
No, I'm so glad to hear and know that our Professor Ada she has been there all throughout till the end. Thank you very much. Anyway, I would like to echo what Professor Awa said, everything about the program. I don't want to repeat it, but I just want to echo. And the main person of SAO is our General Secretary, Azad, who probably has left. And he's lucky to have people behind him who, like Lalit, Namrata, and Rajesh. I invite him, I wish we have people like them. But still, they are also helping in SAO, whether it is conducted in Nepal, Bangladesh, or India or Pakistan. That's what I look forward to. Again, and I must thank the organizing team, for picking up the right people, as the panelist, speakers, and moderators. They all have done an excellent job. And having all said, I want to stop here because it's already it's 7:30. Over to Ben now for vote of thanks. Is it all right, Rajesh? Or is it?
Yes, sir.
Okay.
Yes, sir.
Okay.
I think
Thank you very much.
we need to thank Ben Limbu, sir. He's worked the hardest for this
Absolutely.
webinar. He's really done it in such an organized manner. And it looked like
He's a man.
to me. Yeah, he's really worked very hard. Every single detail, right from sponsors to choices of our backdrops, and so many things he's coordinated from all over the SAARC countries. Got representation from each and every country, even from Maldives, which really doesn't participate too much.
That is very important.
Yeah, see.
Yeah.
Very important.
Thank you, Professor Rajesh, sir, for giving me a floor. I'd like to thank Professor Malla, sir, who used to be my teacher, and now also he's my teacher in my medical school. And then also Professor Rajvardhan, Azad, sir, Professor Namrata, ma'am, who were ready to help me at all the time when I just give a call, and then they are ready to help me. So I'm so happy. Even Professor Rajesh and Dr. Eli was an instrumental to help to perform all the scientific program for this webinar. Similarly, I'd like to thank Professor Aba Hossain ma'am, who is President-elect for APAO, to come and then give a blessing to our webinar. And similarly, the webinar was actually a combination of low setting with limited resources, how we manage cataract to well-developed, good infrastructure center, talking about the modern surgery on cataract. So it was a proud moment to give our audience complete knowledge from basic, like pre-operative evaluation to the best of best advanced technology to provide a good outcome to our patients in SAARC region. It was really a good talk. I must congratulate all the speakers, eminent speakers, who are also not only the SAARC leader, but also they are a global leader. They are the global leader who took part in our webinar on our request. I must congratulate and thank all of them. Similarly, the panelists, I think some of the panelists are so experienced that I was not even born when they were practicing ophthalmology. So I must thank all of them for coming and giving their expert panel comments on our presentation. Similarly, I would like to thank Dr. Samili Jafar, who is bold enough to bring out what the limited resources country can contribute to reduce the cataract blindness in SAARC region. That was a wonderful presentation by Dr. Samili Jafar. I must congratulate her as well. Similarly, out of the box, I would go and thank Sun Pharmaceutical for helping us to organize this webinar from Nepal. And thank you everyone for participating in this webinar. We have more than 300 participants registered and more than 200 live viewers for our today's program. So congratulate everyone and thank you and namaste.
And to you, Ben.
A big thanks to Ben.
Thank you.
Okay, big thanks to
Thanks to Ben.
Everybody is
Thank you,
thank
Ben. Thank you so much.
and Dr.
Thank
Eli
you,
also.
Ben.
Dr. Eli also.
Thank you,
Dr. Eli.
Thanks to
Eli,
everyone
Eli,
participating.
where is Eli?
Yeah.
Thank you
I
so
think,
much, Eli, and
the
also Rajesh as moderator.
Oh, yeah.
So nice of you,
next,
ma'am.
next webinar is
Thank
on
you.
8th of January and it is retina, and I think the coordinator is Dr. Lalit Verma.
Dr. Lalit Verma.
See you, some of you in Friday in Bangladesh. Dr. Namrata, Dr. Rajesh.
So let it be on Saturday rather than Friday, no?
Sir,
Yeah.
8th January ko hai.
In Bangladesh Cataract Society's conference.
8th January and next, which is
Okay, maybe we can just adjust 1 or 2 days here and there. That's not
Oh, yes.
That we'll see. Chalo, okay. Bye, everybody.
Leave the meeting.
Bye.
Hello, Namrata.
Yes.
Hey, Eli, thank you so
Eli,
much.
thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you.
Thank you.
Thank you, ma'am.
Namrata,
Thank you, Dr.
you look
Eli.
so fresh, Namrata.
Rajesh, you.
Usually it was with marks and now it is so
Yeah.
fresh looking.
Yeah. I was actually in the office at that time. So.
Some of you
I
have
understand, I understand. Yes.
some of you have become indispensable in SAO. Don't you agree, Professor Abha? You know,
Yes.
like Lalit, Namrata, Eli, Rajesh, and Ben now.
We have blessings of yours, Ava ma'am is always positive, always looking fresh, ma'am. You are also looking so fresh.
Yeah, we are going to hand over. We are going to hand over SAO to you.
Dr. Malla, hats off to the leadership of SAO for believing in this young generation. Hats off to you, to
Hand
Dr.
over to the
Awa.
young generation. They are doing a wonderful job.
Have faith and trust in us. And I hope we can carry on for this for a very long time and contribute, as Dr. Awa said, to the development and make it a really strong global event.
Right.
That's what.
Of course.
That's what I learned from her today. Great. Okay. Bye-bye.
Thank
See
you. Bye.
Okay, bye.
Good night.
Good night.
Thank you.
Bye,
Good night,
sir.
all of
Bye, sir.
Good night, Rajesh. Well done.
Good night, sir.
Great job, Ben. Great job.
Yeah.
Ben is a very great communicator. He responds very fast.
Rajesh.